incision and deep fascia. The proximal tibia will be in front of us. So this is the MCL, that is around 6 centimeter below the joint line in the posterior half of the tibia, and this marking is for gracilis and semiti, and that sartorial fascia comes over that. So deeper skin incision will be somewhere here till that marking, and with the help of periosteum, complete MCL will be done posteriorly, and then the dissection will be done in the posterior part of the tibia with the help of periosteum, and then put a homen, something like that. So this homen is by Arthrex. Advantage of this part is transparent. So even if it is below the posterior part of the tibia, anything you can see in the siam without any disturbance. A simple homen, if you put, sometime you will have problem of the vision because that will be the metallic part. So this homen will take care of your MCL as well as the hamstring tendon, and it should be subperiosteal till the neck of the fibula. You can see fibula will be somewhere here. Till the neck of the fibula it will be there. Now this part is completely free. Your MCL is back, your hamstring is in back, and then you take the guide wire, and your guide wire, you have to put two guide wire, one just above the level of this hamstring tendon and aiming toward the tip of the fibula. Any of these two you can put, whether posterior or anterior. ये रिवर्स में है बेटा, इसको ठीक करो जरा. But putting posterior one will have bigger length. Yeah, this, and this is at the tip of the fibula. Many a time tip of the fibula vary, खोल दो बेटा. Sometime it may be proximal, sometime it may be distal. So better to place it around 10 to 15 millimeter below the joint line. इस तरफ आ जाए. So first K wire, confirm it in the C-arm, and then take the another K wire just parallel to it, a centimeter or 1.5 centimeter. Eccentric लगा बेटा, चाबी दो मेरे को. Apart, and it should be exactly parallel to the previous one. इसके बाद 100 रेडी करके रखो. नहीं, ये के वाई ठीक नहीं है, दूसरा देना गुड्डू. So always check your K wire should be a straight one, and this is thinner K wire. Usually it should be 2.5, because after osteotomy this gives support to your bone at the time of destruction with the lamina distractor. जहाँ सर का फोन है, बात कर लो. So after putting the K wire, you have check in the C arm that both the K wire are parallel until the tip of the fibula it is. Now take the saw. Your saw, Homen कहाँ गया? Your saw should be below the this K wire, not above the K wire. इसको वायर कटर है. नहीं तो गड़ जाएगा. कटेगा उससे थोड़ा सा. परफेक्ट. ये नहीं, ये कटेगा, इसको पार करना. छोड़ दो, छोड़ दो, इसको पार कर देता हूँ, तो पार करने में भी दिक्कत होगा यार। चलो खोलो। Perfect. So your saw should be below the K wire, above the hamstring, with your humen protecting humen below. And at the same time, you should be very protective that it should not be too posterior. And also confirm this in the Siam also. And check this cut in the Siam. It should be around 1.5 centimeter from the lateral cortex of the tibia. This is horizontal cut. Another cut of the tibial tuberosity, that is the vertical cut. So this is the biplanar osteotomy. So this is biplanar osteotomy. One advantage is the bigger contact of the osteotomy. Another advantage, you are not disturbing the height of the patella because patella tendon remain attached to the tibial tuberosity. In this way, your height don't get distracted. Chisel. And after cutting this, बड़ा वाला hammer. So this is your chisel. There is sets of chisel. Start with the bigger one with your protector sleeve down. इधर से पकड़ लो इसको, उस तरफ से पकड़, hammer दो. Usually this end should be towards the K-wire side. Next please. So these are the series of chisel. Then this is facing opposite to that. Next please. And again you should check the position of your chisel toward the lateral cortex in the Siam. This has to be very gentle and slow. Anything fast or harder will lead to break in the lateral cortex. The third chisel, and you can see this osteotomy site is getting gradually opened. Next chisel, I think this is the fourth one. Yeah, so all these has been this done. Then take it out, and then distractor. This is the distractor. Hammer देना, counter दे देना उधर से. It should be closed completely, and then you place it. Usually it should get placed in the posterior half of the tibia. If anything you want to more and opening more anteriorly, then you should place in the anterior half of the tibia. Counter दे दो बेटा उधर से थोड़ा. So again you have to check this in the Siam. It should be positioned till the level of your osteotomy only. Yeah, valgus mandin. And there should not be any valgus from your assistant side. And let's distract this, whatever the angle you have measured previously. Suppose it was measured, it's now its opening is 9. Suppose whereas correction angle was 12. So this is the 13 mm of destruction. Now give me the wedge here. So this is the wedge. Take it back. So this function of this is this will keep the osteotomy site distracted. Now you place the lamina spreader. It is oh yeah. So this is the problem with the saw bone. Yeah. So this you just place it. So give me one K wire, please. Yes, it all. So whenever many a time at the time of ये पकड़ो, osteotomy and dissection, you feel your lateral cortex is getting broken. So this is the safety K wire you can put at the level of Guddy's tubercle from proximal to distal in the lateral part of. One more, please. That's it. One more. Ideally, one is enough, but it's sawbone, so we'll put one more. This will prevent the breakage of your lateral cortex. Go, go. Now open this. थोड़ा और जाओ, थोड़ा और जाओ, थोड़ा और जाओ, थोड़ा अपनी ओर लो, थोड़ा सा अपनी ओर लो, थोड़ा, 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 बस ठीक, दैट्स इट। ये प्रोफैलेक्टिक के वायर है और चूंकि 100 बोन है तो टूटता ही है, उसमें इलास्टिसिटी होती नहीं है। सो दिस इज द लेमेना स्प्रेडर and this is the osteotomy opening that you have measured. Okay, so if you want to more correction, that is the standard posteriorly, your lamina spreader should be in the posterior half. If you want more correction anteriorly, in case of if you want to do PCL reconstruction with high tibial osteotomy, then your lamina spreader should be in the anterior, so that you have more opening in the anterior part in comparison to posterior part. So you can see the opening in the anterior part is more in comparison to posterior part. A little bit flex. Alright. So it's not so easy to always correct the sagittal angle. It's easy to correct the coronal angle, but it's not always easy to correct the sagittal angle. इसको लॉक कर दो, लॉक करो, यहाँ now give me the plier to remove this wire. या इसको वो जो मशीन दे दो. कोई नहीं, निकल जाएगा वो, कुछ भी है, सेंटिक एक सेंटिक. So I have taken, इसको पकड़ के रखो, पीछे जा. I have taken the anterior wire. Now give me the plate. नहीं, उसको रहने दो, प्लेट दो. So this is the peak plate by the R-Threx. Advantage of this plate is the variable angle, but at the same time disadvantage, you don't have facility of that golden screw that compresses the lateral cortex. So पकड़ के रखो दोनों इनको. Perfect. So again you check the position of the placement of the plate on the C arm. Dill. उसको वाइब्रेशन पे कर दो, मुझे देना जरा. and this screw should be parallel to the joint line. You also check in the C-arm also. स्क्रू दो 60 दे दो 50 आएगा इसमें छोटा है। चकनी है इसका। पास करो पास करो पास करो।
ACL with HTO, you make the TBL tunnel, and
या
after that
टी
you
बेल्ट
connect it.
या
So you use it as a-
छोड़ो होल यहाँ बनाना। तो तुमने पतला वाला वो दिया नहीं ये ना वो पतला वाला मोटा वाला ड्रिल बिट दो। क्या था ये था ना। So this should be parallel to the joint line
Okay.
and should be at appropriate level. पकड़ के पास करो बेलकस करके रखो ऐसे। So advantage of this plate is the variable angle. So in case of ligamentous reconstruction at the same time you can direct a screw. Only thing you have to keep the reamer inside the tunnel in the tibia that you have made for either ACL or PCL or both. So the first screw, at least two screw first in the proximal part. सेम साइज नहीं ये लॉक हो जाता है उसमें टॉप लिमिटिंग नहीं होती है एंड बेसिकली दिस ऑलमोस्ट स्क्रू गेट you can say melted with plate. This is not the exact word. So this plate thread is whole thread get maybe get sometime destroyed by this screw only. And once this get is destroyed, if you want to put another screw in different direction, again this will take the thread of your screw head. New screw.
Suppose we are applying too much of pressure, can it sink inside the plate? क्योंकि तो imprint बना रहा है अपना,
Yeah.
तो अगर बहुत pressure लगेगा तो फिर वो अंदर ही चला जाएगा screw.
This plate may break if you
Hole can damage.
yeah
Like
hole can be
bolt
damaged
is getting sinked in the bone.
synced in the no this much will not be initial 3/4 thread will be destroyed. चलो ये पकड़ लो एक हाथ चलो 30 दे 30 दे दो No, there is no polar screw in this. You can see. So advantage of polar is golden screw. In case in that tomofix, that is not here. So if any breakage in the lateral cortex, then it's difficult to compress with that golden screw in this plate. Good morning. So these screw. So if you are doing it for ACL reconstruction at the same time, try to keep the plate in the posterior part. So this will maintain the your posterior opening more, so that your slope should be toward the zero angle. If you are doing for the PCL reconstruction with varus deformity, you should place the plate in the anterior half of the tibia. Yeah, so that slope will get increased.
So 48 cents.
50 though, 55 will be fine. So this is the last screw. Again check this posterior screw in the lateral view also, because direction is so that very high chances of this screw to penetrate toward the posterior aspect of the tibia.
Now बच गया.
Do you place the screw at the end or during the beginning itself?
Pardon?
Do you place the screw at the end or the proximal row should be fixed initially itself?
Usually we used to place two screw in the proximal part, two screw in the distal part. Then we take everything, then check the this posterior slope and everything with the lateral view. हाँ थे ये plate little bit thicker. हाँ. So take the screw, ये key देना. Now take the this lamina spreader, key यहाँ पे. Then take the K wire, last K wire, खोलो.
Any concept of spacer screws in the artery split?
This is puddu plate they have. इसको निकाल. Puddu plate है दिखा.
Yes, sir. Screen पर sir, just a second.
छोड़ दे बेटा, छोड़ दे. रिवर्स किए बेटा. So this is the protection K wire for prevention of breakage in the lateral cortex, also called as hinge K wire.
We can remove it or we keep it?
Yeah, after fixation you can remove it. You can put it before starting the osteotomy part also, or in mid of the surgery when you feel your
Someone places a screw instead of a wire
yeah.
and leave it
Uh,
after.
if there is breakage of the lateral cortex, if there is breakage of the lateral cortex, then you can put a screw in place of K wire. So, so this you can see, you can
I mean, we've done up to 17, 18 degrees. We've not used bone graft, even in one case out of. Okay, so union is not a problem because the way the osteotomy is designed, because it's biplanar, so the front is still in contact. Plus, the lateral hinge should not be broken. Now, if you break the lateral hinge, in the sense that just a crack is not a problem, but if it breaks and separates, that's a different situation. There, you may have to add bone graft, but otherwise, you should not have to add bone graft. They all heal up quite well and very quickly.
so you can see the posterior opening is more, anterior opening is less. That what you want. At the same time, your tuberosity should be in close contact with the proximal fragment. And as sir was telling only because of this, the healing is very fast. And on the lateral side, you can see even if there is little bit of crack, this will get compressed if you put that the golden screw, if it is tomofix type of design it is. Another design, that is the puddu plate. Manish sir has asked about the any spacer thing. So again you can put this spacer. Size is variable. Whatever amount of the opening you want, you can place it there, and you can just stabilize with the 2 screw proximal and 2 screw distal. Only problem with this short strut implant, this is called as short strut, this is called as the long strut implant. The stability is little bit compromised with this, and any breakage in the lateral cortex with this plate, the chances of failure of this osteotomy, that is the non-union, is very high. So whenever if you are using this short strut plate, that is the puddu plate, your lateral cortex should not be break in any form. So that precaution you have to keep in mind whenever you are using
Any
this
other
puddu
disadvantage
plate.
of this metal block?
Advantage of this met
Any other disadvantage of this metal block?
any disadvantage, that of course you will not have callus in the area where you have placed this metal block.
It will be a weak construct.
So it will be in the future, this again will be a weak construct, and again whenever you will remove, this much of the area will remain vacant. If you leave it as such, this will get filled with the callus completely.
Right.
But if wedge is there, so this much of the wedge will prevent coming the bone at the osteotomy side. So these two are the bigger advantage. One is the lateral cortex breakage with this strut. Another is that amount of the area still remain open. And disadvantage of this, don't have golden screw. Advantage, this is the polyaxial plate, so you can place your screw in different direction, particularly if it is ligamentous reconstruction at the same time. And disadvantage, don't have the golden screw. The this tomofix dikhana.
For the benefit of the students, can you show the miniature method of measuring the connection angle?
So
Because the circular
usually it
aspect
is on the this long leg
is the
film
circular
only.
aspect.
So you just uh, you just take the mechanical axis of the femur, mechanical axis of the tibia, and this angle of the complete long leg axis, complete the mechanical axis where it comes. So this much of the angle you just calculated at the level of the tip of the fibula there,
Right.
and whatever the angle this comes, that osteotomy angle should be here. But nowadays there is lot of software also. At Apple phone you will have osteometer, on which you can very easily calculate the angle. Like this I can show you how this get calculated. It's very easy, very fast. You just place the uh, this is the osteometer. This is software. You just click the camera, go to the gallery, whatever, or if you want to take the photo, you can check the photo also. You just in the gallery check the any long leg film it is, if it is there, you want to place long leg film. So this is the long leg film. It is here. You just place the angle there and confirm it. So this confirmation done. You just place the ball at the center of the this hip joint, and then center at the ankle joint. This, and you, if you place this HTO, you can see at the and there is two other line you have to adjust. One is the horizontal line of the knee joint along the tibial end, and another line at the osteotomy angle. So this is the fibular tip, and this is at the junction of the metaphysis diaphysis, where you want to start your osteotomy part. And this will say at 62% of the weight bearing, correction angle is 7 degree. If you want to keep your long axis at 50 degree, that is in the center of the knee joint, then correction is 4 degree. If you want to increase to 70 degree of your lateral side of the joint line, then the correction angle is 10 degree. So this is very, if you simulate this, how this osteotomy will looks, you can see this is the simulation. This osteotomy looks like this at 70% of the weight bearing axis. If you keep at the 62, then see at 62 this will look something like that. So this is how this will be in the post-op time. Post-op time. So this
software you
is,
have downloaded, huh?
yeah, this is available on this Apple. You can take from there. It's very simple. Osteometer.
Okay,
Just check me.
you can share it.
Yeah, definitely. This is,
You can share it in the group that
yeah,
arthroscopy
this
group.
is, yeah. Yeah, it's very easy. I do all of my this correction with this only. It's very easy. So Miniaki is one of the method, and this you can do it by this method also. So any further question? If it is not, then we can start the main session. Good morning, everyone. So after completion of HTO workshop, we are moving to session 6, that is the patellar instability, and moderator is Dr. Ashwini Gaurav. Dr. Ashwini Gaurav, please.
Morning, everyone. This will be session 6 on patellar instability, and I'll like to invite all the chairpersons for the session: Dr. S.S. Jha sir, Dr. Deepak Joshi sir, Dr. Rakesh Chaudhary sir, and Dr. Bharat Bahera sir. And the
Well, good morning, friends. I'm very happy to see good gathering for this patellar instability workshop. Well, as far as knee joint itself is concerned, one has to have strong legs with powerful knees. When it comes to power in the knee, it is not only the ligaments, it is also the muscles that surround them. As far as ligamentous stability is concerned, there are many which makes the knee unstable. But today we are going to confine ourselves to patellar instability, and without wasting any time, Dr. Rakesh.
Uh, Good morning, everybody. Without any much ado, we'll start the program. May I request Dr. Bhushan to start his talk on surgical management of patellar instability.
Good morning, all.
Next, John Kubala.
Yeah, good morning, all. So it's something very close to heart, something which I normally like to do. It's patellar instability. Um, that's how the rising sun should look. and sometimes it doesn't, and that's what we are going to work on. I'm not going to talk much on the pre-op planning because Dr. Rajiv is going to talk about it, so I'll rush through it. Uh, what has been thought till now was to get the patella on trochlea. Essentially what you need to do is get the trochlea on under the patella. So rather than getting the train on the track, get the track under the trains, and that seems to be working really well. It's a wide spectrum from a single traumatic episode of dislocation to a habitual dislocator such as this. So we need to find the cause and treat the cause accordingly. The traditional concept of doing a massive lateral release and medial reefing for every patellar dislocation is not true anymore. We need to address the cause which has caused the patella to dislocate and treat it accordingly. I will not go into biomechanics and won't talk much about anatomy. We know the DJOR classification for the trochlear dysplasia. We know about various ratios that we need to look at. So all of these will need to be looked at really seriously. So you need to look at your Caton-Deschamps ratio, your Insal-Salvati ratio. You need to look at something called as trochlear index, and all of these are important. Now, don't concentrate on the north, concentrate on the knee there, and you can see the increased Q angle in her, and that's what is very important. Same hypermobility is a very important way of reason for recurrent patellar instability. A couple of papers where there's a good algorithm written, and this is how I normally do it. So acute episode, standard physiotherapy and RICE treatment is a chronic instability which is very important. Whether the anatomy is normal, bony anatomy is normal or abnormal. If it's normal anatomy, then you just do a MPFL reconstruction plus minus lateral release. You might even want to do a medial plication and get away with a simple treatment for such kind of patients. But when you have abnormal osseous anatomy, that means when you have problems with alignment or rotation, you need to do a derotation osteotomy or a realignment osteotomy. When you have a trochlear dysplasia, you want to think of trochleoplasty for B and C, sometimes even for D also, that you can do a trochleoplasty. And when there is an increased TTTG distance, you want to change the patella height, where you want to distalize, proximalize or medialize the tibial tubercle and transfer it according to the need of the knee as such. You need to look at the clinical examination properly. Let's quickly go through 4 or 5 scenarios. So this is a typical patient that comes to you, 15-year-old girl, twisted a knee while dancing, felt the patella coming out and going in. First episode, not that bad now, clinically has some effusion and tracking appears completely normal. So she's obviously not a candidate for surgery. All you need to do is just conservative management, work on the VMO, and there's a good chance this may not happen. It's the simple first dislocation that we always treat conservatively. It's the second dislocation and further on that you need to do something about it. So let's see, this patient has grown up by 3 years. Now she's come to you with a second episode of dislocation which happened a year back, third episode which happened a few months back, and the last episode which occurred in her sleep. The moment you get atraumatic dislocations, you are in a difficult scenario. You need to sort this out and assess the patient properly. So look at the alignment, look at the Q angle, look at the TTTG distance, and decide what you need to do. So this patient, TTTG distance is 18, our acceptable value is about 17. If you look at the MRI is 13, so you need to do what is required to be done. This is just a borderline TTTG distance, so I would rather just go for a MPFL reconstruction. Those of you who are interested in anatomy, Laprade as usual has written a brilliant paper on anatomy of the medial side of the knee, and it shows exactly where your insertion of MPFL is on the patella as well as on the medial aspect of the femur. Of course, as things have it, there is also a medial patellar quadriceps ligament, there is also medial patellotibial ligament, and there is a medial patellomeniscal ligament. I don't think we can replicate every capsular thickening, but MPFL seems to be the most consistent structure that needs to be done. We generally use a simple gracilis graft to recreate MPFL. You have various ways of doing it. The way I do it is I drill a couple of drill holes in the patella, I fix it with 2 anchors or a V-shaped tunnel in the patella, and fix it on the anatomic point, which is called as a shortle point. I'll probably show you when I'm doing the live surgery in a few minutes time. And the graft has to be extra synovial. That means the graft has to be between the layer 2 and layer 3 of your medial side. So this is a quick way in which your MPFL is done. So you do a medial dissection at the medial border of the patella. It's a superomedial border, not the medial border. And you make a subcutaneous, a soft tissue tunnel between layer 2 and layer 3 under the VMO. And where you pass your graft, so in this patient, I have done a V-shaped tunnel. So I put two converging bead pins followed by 4.5, and just using a simple nixter, I pass the graft in. This used to be the olden way as to do it, but the present way of doing it is two anchors for me. This is called as a Shottle scale, or it's a radiolucent scale that you can use it for deciding the isometric point. And the isometric point is 2 millimeters proximal and anterior to the intersection of the Blumenstadt's line and the posterior cortical line. So if you find that point, you can easily be certain that you are replicating the anatomy. And that's one of the standardized way of doing your MPFL. You pass your graft through the tunnel that you have created in the patella, pass it under the in the tunnel, and fix it with the screw on the medial side of the femur. So that's roughly how it will look nowadays. So this patient is sort of my standard X-ray, where you will see two anchors in the proximal part of the patella. The anchors have to be in the supra-equatorial position or northern hemisphere of patella, and you need to fix it properly with minimum tension. The MPFL is a check-rein ligament. It's not a standard ligament which will hold the patella all the time. It only stops dislocation. Okay, so let's make it slightly more complicated. Now the TTTG distance is 23 millimeters, but the rotation is normal. So you are faced with a person like this. Normally it's a teenage girl, 16, 17, 18, and you are seeing someone like this. Now arthroscopy shows a massively laterally overhanging patella with a slightly flat trochlea. Now these patients need a TT transfer. I'll hopefully show you today when I'm doing the surgery. You need to get a nice chunk of bone in a L-shaped manner, so that your tibial tubercle is well protected and the patellar tendon is not disturbed. And you can medialize it. So you can see it's medialized by about 8 millimeters, which is significant amount, but that will get your TTTG distance in the zone of normalcy, and that will give you a really good stability. And quite a few times, once you're done that, the patella becomes so stable that you don't feel that you need MPFL. I always add a MPFL to all my surgeries. This was one of the patients where I had just done a medial plication. This was a few years back, and that's how your tibial tubercle transfer looks. Those of you who are keen-eyed will see that I have distalized it by half a centimeter as well. So you can see the tibial tubercle is not fitting perfectly in the groove. It's come down a bit. That's a very useful way of correcting patella alta, because when your patella engages in the trochlea, it becomes stable. That's my standard X-ray nowadays for MPFL and TT transfer. So you have two anchors, and you have your TT transfer done. One more. This is a slightly bigger patient, had a bad dislocation and the patella did not reduce. So the patella was stuck and someone had to physically reduce it under anesthesia or sedation, and that's how the X-ray was. Now always be very careful when you see such X-rays, because you can miss something like this. So this was a patient who had a massive osteochondral fracture of the patella. The whole inferior half of the patella was completely gone, and that needs to be fixed at the same time. So these are patients where you don't wait for long. You go inside after X-ray or MRI which shows the loose body and fix it either with screws. I've moved to suture technique now, because those screws sometimes become prominent over time and they cause problem. The vicryl sutures work brilliantly in most patients, and they tend to heal very fast. So that's the same patient's X-ray, and if you can see there, that's the fragment which is completely fixed, if you can see that. So it's important to look at these fragments. So that's the same patient. Intraoperatively, you can see the size of the fragment there. You can see the size of the crater now, and how it's repaired with just vicryl sutures, and it works really well when you can just add a MPFL and TT transfer on top, and that works really well. Lateral release in isolation, I won't suggest that to be a very good surgery for patellar dislocation. It works counterproductively. That means quite a few times when you do a lateral release, sometimes even that can cause patella to be more unstable. So I won't suggest lateral release to be done. It's better to do a lateral lengthening, especially in patients of MPFL reconstruction, TT transfer, trochleoplasty or PFJ replacements, where you can do a lengthening of the lateral side. Okay, let's see one more. So similar kind of patient now. That girl is 17, multiple dislocations. Now she can voluntarily demonstrate dislocation. That means she can just move the knee and the patella comes out and goes back in. So these are the patients who have trochlear dysplasia with muscular abnormality. So these are the patients who need a groove deepening trochleoplasty, which looks something like this. So you can do a lateral procedure or you can do a central procedure. The Dijor way is what I normally follow. So I normally do this way, but instead of anchors, we now use, instead of staples, we now use anchors, and that works really well. And that's one of the patients where you can see the groove pre and post, where a groove is nicely formed. It always looks that scraggy on the rotational profile later, but the patients are really, really happy when you do a trochleoplasty as such. One more, Dr. John is going to show something later in a similar category. So this is a 36-year-old female with very severe apprehension. So the moment someone touches the medial side of the patella, she jumps because she knows the patella is going to subluxate. So obviously you can see a valgus deformity in the knee. And when you do a trauma CAD or bone ninja planning, you will realize that there is a significant lateral deformity. And such patients are ideal for a medial closing wedge DFO. And that works really well when you do something like this and the knee becomes superbly stable. One more thing is about derotation osteotomy. So quite a few times you see patients who are able to do that. That means the internal rotation in the hip is massive and external rotation is quite limited. So they are able to sit in the Taylor's position, that's called Taylor's position, but they're not able to sit cross-legged like normal. And these are normally teenage girls who have a very severe deformity, and they are the ones who have even dislocation in flexion. So these are patients where you need to do a derotation osteotomy. So that's the patient where you can see the patella is sitting over a lateral plateau. It's a type D Dijor trochlear dysplasia, but look at the rotation of the femur. The femur is sitting like that rather than sitting straight. So that same patient now post-surgery looks fairly normal. So I do a fair number of derotation osteotomies where you make a horizontal osteotomy parallel to the joint line and you rotate the distal fragment externally and fix it like a DFO. And you can be very clever and cheeky and even correct the valgus at the same time in these patients, and that works really well. That's one of my patients. As you can see, a big cut, a massive lateral release, a derotation osteotomy, a TT transfer, and MPFL reconstruction all done in one go. And that's the derotation I'm talking about. So you rotate the distal fragment externally by taking a part of the biplane out, and that works wonders in most patients, and I got a good fair number of patients who have done really well. Well, if all fails and patient comes quite late to you in 40s or early 50s, you always have the option of doing a PFJ replacement and getting the alignment right. In PFJ replacement, you can easily work the trochlea, you can change the rotation of the femur, you can medialize your patella button to get it stabilized. And that's one of the options in recurrent dislocation with arthritis as well. So it's ultimately a controversial problem with multitude of treatment options, but what most important thing is to understand is that there is no single gold solution. You need to tailor your treatment according to your patient, find out the cause of the recurrent dislocation, and try and solve the jigsaw puzzle where as many pieces can be brought back to normalcy. The patellar dislocation should become normal. So your patella will stay in center rather than being in the lateral side. So you do a trochleoplasty, sorry, I'll show you what so you have a trochlea which is non-existent, you do a new trochlea, you have your patella sitting on the lateral side, you create a new MPFL, and that will get your patella stabilized and the knee moving fine. Thank you.
So, very nice presentation, Dr. Sabnir. Just one question. A patient who comes like after first dislocation in the OPD who has reduced himself, like suppose after the trauma, what all investigation apart from X-ray you would advise for him?
So for a first time dislocator, I won't investigate further. I'll just do a X-ray. If I'm worried about an osteochondral fragment, I will do an MRI. But otherwise, for first dislocation, just physiotherapy. So generally, the moment you get more than 2 dislocations, we call it a recurrent dislocation, and then you start investigating the patient further. Quite a few times, single episode tends to heal with good physiotherapy.
So at first go, we don't have to look for the any trochlear dysplasia and all.
Not for first dislocation.
So, any
Well, if it is a case of habitual dislocation, how do you start your assessment and how do you plan your treatment? Is it different?
So for a habitual dislocation, you need to find out what the cause is. Habitual dislocation is normally the extensor mechanism is short. So your vastus lateral patients done in pediatric population. So they have scarring or adhesions in the lateral extensors. So in such patients, you do a lateral lengthening of so you do a vastus latalis Z lengthening, you do a massive lateral release, and you proximalize the tibial tubercle because it's short. And then you get the patella in with a MPFL, and that usually works. So I've got a series of habitual dislocators who have gone back to normal by doing this. And this was a technique described by Feng Hua from Beijing, which works quite well.
You made two statements. You said you always add up MPFL.
I knew you were going to catch me on that. Okay.
No, no. So I just want to make you further clarification on this.
So I feel MPFL is a Chekrein ligament, and whenever you're doing anything for your patella, that's the last straw, and that's the first one that breaks. So it's always important to have a medial holding structure which will stop the patella from dislocation. So MPFL only works from 0 to 30 degrees of flexion. It doesn't work beyond that. But that's the position in which your patella is going to subluxate or dislocate, because it's not engaging in the trochlea. So I feel every patellar instability, I always add an MPFL at the end, and hasn't failed me.
Right, I fully agree. And then you made another statement that you do not prefer a lateral release, rather a lateral advancement. Is that correct?
Lateral lengthening.
Oh,
So
sorry,
you do a
yes.
Z lengthening of the lateral side.
Right.
When you do a lateral release, it somehow makes the patella more unstable if you do a massive lateral release.
It actually tends to tilt the patella rather than make it more lateral.
Sometimes dislocators are normal trochlea with normal TT, but they have a stretched or wavy MPFL. And they have apprehension that my patella will get dislocated. In such case, do you again go for MPFL in front of like this?
No, so I'll do a new MPFL. So you no MPFL reconstruction. So that MPFL is healed in a lengthened fashion. The analogy is a PCL which is stretched out with a positive sag. So you have a healed ligament over time because of recurrent instability, which is lengthened and inactive now. So you need to do a new one.
So your first case was first time dislocator that was managed conservatively. Any indication where you will operate at the first time dislocator?
That's a fragment only, osteochondral fracture. Otherwise, I would be loath to operate immediately. It's better to wait. Even the patients are also ready clinically and mentally that they have a dislocation problem. One episode, most patients are saying, okay, we'll see what happens next.
I think, sorry, so it's important to assess them very carefully in terms of the opposite side as well. So a lot of them have bilateral problems. They may dislocate one, but they already have some elements of problems which will lead to instability on the opposite side as well.
Important point, yes.
As the first time event of dislocation is concerned, you have talked about conservative treatment. Would you like to outline the time period for which you want to immobilize the patient?
So
or would you not like to immobilize
I normally advise 1 week of immobilization, but no plasters. I only give a standard long length knee brace and ask the child or the teenager to be immobilized in that. Because if you do it more than a week, your quads go very weak, and some people even are struggling to activate the quads after that. They have a massive quads weakness. So 1 week is maximum.
Right. You did mention about taping, and I would like the audience to know that taping definitely has a advantage.
So there are two things which work really well. In short term, I mean, let's say for a few hours, a few days, you can use taping as an option. So kinesio taping, where you're pulling the patella medially, works quite well. The true pull light kind of brace, the dynamic patella extension braces which hold the patella in the groove, also work quite well. But I think their effect or their effectivity goes down after a few months, and patients start dislocating even the brace or the tapes off. So you need to know it's a stopgap arrangement and not a permanent solution.
Torn MPFL with type C trochlear dysplasia. So what would be the treatment of choice? Would you do a tracheoplasty or in the first setting only MPFL reconstruction?
So if the patient comes to me, he or she is normally she, clear tracheoplasty and MPFL reconstruction. So I would like to do one surgery that will last for life. Because if I do an MPFL, then that's going to stretch out in a couple of years' time. So you are now relying on MPFL to hold the patella and move it in the range of motion rather than being a check-in ligament because it's type C. So type C is when there is slight bump. So the patella will not stay there. MPFL will physically hold it throughout the range of motion, and that's going to stretch out with time. So if that patient comes to me first time, I will do a trochleoplasty. Of course, that he or she has to be skeletally mature to do that, and then along with that an MPFL. But most patients come to me after 2 or 3 failed surgeries, and then that's what I normally do.
So till type B you will reserve trochleoplasty, right?
Type A. Type A you leave it. Type B, C you operate. Type D is when you need to add derotation and trochleoplasty. That's one of the tricky situations to handle.
Do you think it's depend upon the number of dislocations also? Because many a time 30-year female with first time dislocation having this MPFL tear, and almost 70-80% of this type of patient having some kind of trochlear dysplasia, whether it's A, B, C or D, depend upon. So suppose first time dislocator with type C, 35-year female with MPFL tear.
So I'm sorry I wasn't clear. Trochleoplasty is a young patient surgery, not for someone over 30-35.
Yeah.
Because you're already getting signs of chondral damage, so you should not be doing trochleoplasty in that age. I think under the age of 30, with a pristine joint, I will do trochleoplasty.
So, great talk. Like moving forward, thank you very much, Dr. Sabnis. Now I would like to invite Dr. John for his presentation on the Fulkerson osteotomy in patellar dislocation.
I'm going to talk just basically about the Fulkerson osteotomy because Bhushan has really gone through the various steps. But just to reinforce certain things is that the patellar instability is most often multifactorial. So you don't always understand it properly. So you need to spend time in trying to understand what are the problems, whether they are mainly bony, soft tissue, or it is the force vectors that are a problem. And the earlier surgery, as was mentioned, of lateral release, medial plication, on its own doesn't work. You very often have to do an MPFL reconstruction, and you need to correct whatever bony malalignment or malrotation there might be. And then you may have to add a medial patellar tendon shift, which could be bony in the skeletally mature or soft tissue in. So you do something like a Rube-Goldthwait procedure. And trochleoplasty is another way to deal with a trochlea that is deformed. Now the first paper, the original paper by John Fulkerson was in 1983. And it's interesting that he has really looked at this very carefully. It's basically a modification of the Elmsley-Trillat procedure, which was medialization of the tibial tubercle. What he added to it was this medialization and anteriorization of the tibial tuberosity by cutting the slope slightly obliquely. So you cut from it's sloping up on the medial side and down on the lateral side. And then as you translate the tibial tuberosity, it also gets anteriorized as opposed to when you make a horizontal cut or something parallel to the surface of the proximal tibia. Now here's a patient. This is a 23-year-old female with recurrent dislocation of the patella. You can see it's almost a habitual dislocation because of the huge tilt in the patella. Also, the trochlea is deformed. The MRI will show you an MPFL problem right there. And there's no obvious severe valgus or varus deformity there. The MRI measurements of the TTTG are 22 millimeters, which should be ideally somewhere less than 15. The patella alta was also there. He had a MPFL tear and trochlear dysplasia. So here we had planned to deal with the problem of TTTG distance and patella alta with a Fulkerson osteotomy and the MPFL tear with an MPFL reconstruction. I think the surgery for trochlea, the trochleoplasty surgery is still something which is in a stage of evolution. There are some people who strongly recommend it, others say it's not really necessary, and if you do the others, it kind of reforms with a period of time. So here's the approach. Now you need to get because we're planning both an MPFL and a Fulkerson, it's a longer incision. If you're just doing a Fulkerson, then you just need to do the distal part of the incision. You need to have about 5 to 6 centimeters of the tibial tuberosity exposed. So from the knee, you go down about 6 to 7 centimeters down. Then you measure the distance, so you want about 5 centimeters. So here we've got 5 centimeters of the tibial tuberosity measured. You mark out the point, and then you put in your K wires. Okay, so they are angling towards, so more anteriorly on the medial side and more posteriorly on the lateral side. So it's here, they're introduced from this side. Okay, so there's the osteotomy being done. You can see it's sloping down from medial to lateral, and you complete the osteotomy, take off the entire, so here because we are distalizing, you need to take off the tibial tuberosity completely. If you're just medializing, you can leave the periosteum on the distal part still attached, which helps with healing of this area. But if you're going to do distalization as well, you need to take it off. You need to release all the structures. You need to do your lateral release or lengthening as you like it. And in this case, we're also planning an MPFL reconstruction. So that is done. There are various ways of doing it. You can use staples. You can use just a suture on the lateral side. So in our case, we're just using a suture on the lateral side. This part goes into the point where the MPFL is attached into the distal femur. And we just suture this on the side here. Okay, and this part is usually done by Dr. Arvind, so he can take any questions on that if there are. And then we go on, we measure that, we try to get at least a 1 centimeter anteriorization of the tibial tuberosity. Measure that, we put in our K wires, and then we put in usually 3 screws, 3.5 millimeter, where the near cortex is over drilled to 3.5, and the far cortex is only 2.5. So 3.5 millimeter cortical screws. Usually avoid a washer, but wherever you're worried about the bone, you may have to use a washer. These washers are very thin, so they don't cause too much of a prominence. And once you've done this, you need to make sure you check your stability. Okay, so you check your tracking of the patella and the stability throughout the range of motion before you say that you're done. And like I said, those are the 3 screws that you put in. They are bicortical, so they should go through the cortex. So the length is important. You don't want particularly long screws which are sort of poking out on that side, because the vessels are not far away. Okay, so once you've done that, you should get a good stable position for your patella with adequate release on the lateral side and the MPFL reconstruction. So this is an interesting article which came out recently, 2017, in Arthroscopic Techniques, which tried to improve the ease with which you could do a Fulkerson osteotomy. They designed a jig which would allow you to pass your K-wires and your osteotomy, and also a way to measure the angle, which would also tell you how much you're medializing and how much you're actually anteriorizing with the angle of your correction. So normally we go for about 35 to 40 degrees angle, because more than that you end up with very little or with less contact area, but you can vary that depending on how much you want to anteriorize or medialize the tibial tubercle. Now, what you need to do basically in terms of the indications is that if your TG distance is greater than 20 millimeters, you need to medialize. If you have patella alta, you need to distalize the tibial tubercle. And wherever you have focal chondral lesions, you need to anteriorize the tibial tubercle so that you have less pressure on the chondral surface and will allow the chondral surfaces to heal. So this was an article we published a couple of years ago, which was on 22 cases. I think 4 of them did not have the MPFL. The rest of them had a combination of the Fulkerson and the MPFL reconstruction. So I think in take home, many factors need to be considered. recurrent dislocations can be disabling. It's not a we see a lot of patients who are left alone for many years and are dealing with the disability because no one has suggested them to have proper treatment. You need to plan your surgery carefully because you need to look at all the elements of the problem. You need to address all the problems together where possible. So whatever problem there is, the lateral tight structures, the medial laxity, the tibial tubercle position, any malalignment, so you need to correct the valgus deformity. So we'll be doing a case today with a severe valgus deformity in a child. So we'll be doing an osteotomy, and then if the patella is not sitting properly, we'll also do a Roux-Goldthwait procedure for the patella tendon, and if necessary, an MPFL reconstruction as well. Okay, so thank you very much. And any questions, I'll be happy to take, and then I'll have to push off for the surgery. Okay.
That was very nice, sir. Thank you. What is the, sir, post-operative protocol after this?
Okay, so we put them in a brace, we toe-touch mobilization initially. We don't weight bear them for some time. The amount of, so the only time we put them in a cast is if we are worried about our screws. Okay, if we haven't got really good hold, and that happens maybe 1 in 10 times, and there we would use a cast. Otherwise, we put them in a hinged brace, allow some range of motion gradually, and increase it after 3 weeks, and then full movement after 6 weeks. And by then, they should be weight bearing as well. So,
I am transgressing the limit of my question into joint replacement. Have you ever, in a complex situation where you feel there is deformity also, would you go for this approach for a joint replacement?
So we do tibial tubercle osteotomies in a very stiff knee joint. Okay, so there we've done a tibial tubercle osteotomy along with the joint replacement.
Right.
But there we don't take off the tuberosity, we just keep some attachment and then reattach it at the end. So we evert the patella with some soft tissue still attached to the part of the tibial tuberosity.
Right. And in this particular osteotomy, how careful you are that you do not encroach the medullary canal?
So that's where your K-wires are helping. So you cut above your K-wires. You put in your K-wires and cut on anterior to that so that you're not going into. So there are reports of stress fractures. In fact, Fulkerson himself has published a paper recently with 4 cases of stress fractures in the region of the osteotomy.
So Bhushan was saying that the trochleoplasty should be done in every case, B and C. So what's your, sir, take? We should do a second stage or we should do
I
first?
think so. No, I think I did a couple of trochleoplasties many years ago. I haven't done one for some time because we rely on the rest of the procedures. So we've not been doing trochleoplasty, but that's because there wasn't a very good way of fixing these trochleoplasties, which we could. So as we're getting better methods of fixation, I think there would be an indication for doing them in some patients. What is your indication for them?
Most of the times it's basically type B and C. Basically, I have a trochlea, but we always do it in a second stage. We always exhaust first 1 or 2 procedures.
Yeah, so that's what we've been looking at, and we tend to do the rest, and if it's stable and they don't seem to have major problems, we leave it like that.
Yes, sir.
Okay, but I think there may be an indication for some very dysplastic ones that if you're getting them at a time and that is the cause, then maybe that would be the place to deal with them.
Yes. Yeah. Thank you very much, sir.
So if you look at the proximal tibia, the medial side slopes like this and the lateral side is almost vertical. So if you cut it normally, when you medialize it, it's actually going to go posterior if anything. So what you do is you cut it with a slope from medial anterior to lateral down. Okay, so now you have a slope on the thing. So when you medialize, it's automatically going anteriorly. Okay, and you can actually increase the amount of anteriorizing by increasing this slope of the cut. Okay.
Joint pressures and causing a patella baha kind of a situation?
So obviously you need to measure that and go according to that. So you've done your either insult solver T or CD ratio before, and you just try to get it back to somewhere near normal rather than out of the normal range. You're not going to distalize it too much because then it'll become tight. But here, because you're anteriorizing it, you will not have so much pressure on the joint either.
So
Okay?
intraoperatively, you check the CD ratio.
Absolutely, yeah.
Okay.
So we check that, we make sure, so we've calculated it before and then we do it according to that. Okay, so basically we are not trying to get back to absolutely normal values every time. Okay? Yeah.
So all these measures are pre-operatively.
Planning.
If you see the check X-ray of that patient, can you place sir there?
It was just about how to get it right intraoperatively.
So of it 4 or 5 millimeter what you have calculated there. So if you see the check X-ray, you can see the cut level of the tibial tuberosity and the final positioning of the tibial tuberosity. It was 5 millimeter down there. So that much distance you have calculated previously only by the taking all the parameter there.
Yeah, but you need to check it intraoperatively also to see that you've got that.
Yeah, that distance you can see in the check X-ray. So that much distance you have to replicate intraoperatively. The initial osteotomy was the Hodges. You can see in the lateral view.
So if you see the proximal part of the X-ray here, you can see how much it's been distalized here. Okay.
So initial osteotomy was the Hodges osteotomy, in which just you do the this horizontal osteotomy.
Hauser's, then you had the Emsley,
Emsley,
which is
Trillet.
actually written up by Trillat, not by Emsley himself, but yeah.
So since you are anterioralizing also, so hardly any effect on that.
It's
so
interesting, this paper came out in '83, but it's got more press recently than it had for many years.
So in our paper, the main focus was about the anterior knee pain. If you see the topic of our, it was the mostly 30, 40 year age group of the female. In that there was lot of anterior pain and subluxation of the patella. Hardly some patients were having complete dislocation of the patella. So we did only fulcursion in such type of patients, and there was complete relief of the pain and that subluxation symptom.
Did you have to do chondroplasty in any of these cases? Patella chondroplasty?
No.
Very thank you, sir. So we have the next speaker. We have Dr. Rajiv Raman, who will be speaking on. Okay. So we is by Dr. Ramakant Kumar. So case 1, patella dislocation.
Good morning. So we learned the algorithm to manage cases of recurrent dislocation of patella. So here I'm going to discuss a case with acute osteochondral fracture with history of recurrent dislocation of patella. It's not moving. Okay. So the patient is a 19-year-old female, obese, with a history of injury following sudden fall while walking in the August 2020. She had a similar episodes in 2013, which was managed elsewhere with hematoma aspiration, and multiple episodes between 2013 and 22, which was managed conservatively at home. So clinical findings were painfully range of motion. There was knee fusion. There was no coronal and sagittal plane malalignment. There was no rotational malalignment also. So this is the X-ray, AP view, sorry. So this is the AP and lateral view. You can notice a osteochondral fragment over here. Again, CT scan was done. CT scan is showing hypoplastic trochlea, laterally subluxated patella, and osteochondral fragment. Then further investigated with an MRI. MRI showed normal ACL and PCL and menisci. You can also notice this bone contusion, which is there on the lateral femoral condyle in a case of patella dislocation, which is commonly noticed. So there was a bone contusion on the lateral femoral condyle. So you can notice this is the axial cuts. You can notice a missing part of the cartilage on the medial facet of patella. And also there is a torn MPFL ligament. So a torn MPFL ligament and an osteochondral fracture from the medial facet of patella. So MRI findings were osteochondral fracture involving the medial patellar facet, torn MPFL, TT-TG interval 18 mm, trochlear morphology type B with a trochlear depth of approximately 2.8 mm in Sal-Salvati ratio 1.3, normal ACL and PCL, and normal meniscus. Diagnostic arthroscopy was done. It shows tendency to subluxate patella laterally. Defect was noted in the medial patellar facet, osteochondral fragment located and retrieved through the arthroscopy. So my diagnosis was some medial osteochondral defect with MPFL tear with trochlear dysplasia. And the TT-TG interval was normal, patellar height was normal, and there was no coronal and rotational malalignment. So my plan was fixation of osteochondral fragment and double bundle MPFL reconstruction. As we discussed, I reserve trochleoplasty in cases of failed attempt. Like if this attempt fails and patient again comes with recurrent dislocation, then the second stage procedure is trochleoplasty. So for osteochondral fixation, I did open arthrotomy, medial parapatellar approach. So this is the finding. There was a large defect in the medial patellar facet. So this is the osteochondral fragment. So I fixed it. There are multiple ways of fixing the osteochondral fragment, but this is a small fragment, so I used a crossing suture technique and bio-K wires. So we drilled 4 holes on the 4 quadrants of the defect. First prepared the bed and then drilled the 4 holes, then passed the two number 5 wire sutures. Then the fragment was inserted inside and it was further fixed with bio-K wires. So this is a picture after final fixation with crossing suture technique and bio-K wires. Once it was fixed, I decided to do a double bundle MPFL reconstruction. My graft of choice is 70 in this case because the gracilis was very thin. Particularly in Indian females, gracilis graft is very thin graft, so I usually choose 70. The implant choice was swivel lock suture anchor and a biocomposite screw on the femoral side and suture anchor on the patella side. So this is how I do medial incision. These photographs is from the different patient just to show for the demonstration purpose. So a small incision approximately 2 to 3 centimeter beginning from the superior medial corner of the patella. So first we put a 2.4 mm guide wire, 2 guide wire parallel approximately at a distance of 1.5 to 2 centimeter. Then that is over drilled with 4.5 mm drill bit. The drill is approximately 20 to 25 mm. We try to go beyond that because to prevent any stress fracture in patella. So it was drilled with 4.5 mm drill bit. And this is the swivel suture lock, suture anchor. The graft was fixed. Both the loops were fixed in the patella using the swivel suture anchors. So fixation in the femur, there is a well-described point that I call Sottle's point. So the Sottle's point is basically you draw a line along the posterior cortex of the femur, then 2 vertical lines. One is from the posterior aspect of the posterior part of the Blumenstadt line, and another line is from the most posterior part of the medial femoral condyle. So just one centimeter above the intersection of this line is the point of is the femoral fixation point for MPFL. So this point is called Sottle's point. So, I mean, we also have ready-made kits available today, which can help to pinpoint the Sottles point. So the graft was looked between the layer 2 and 3, that is extra synovial, extra capsular layer, and brought to the femoral entry point. So this is the kit usually available nowadays. So this is the incision which is used to fix a MPFL in a normal scenario. But this case was a different case. So in this case, this is the scenario. I mean, double bundle MPFL reconstruction was done after fixing the osteochondral fragment. So it was fixed on the femoral side with bio screw. So this is immediate post-op X-ray. You can see the osteochondral fragment over here, well fixed. This is 6-month follow-up X-ray. You can notice the entry point, which is the Sottles point. The patella is well centered in the trochlea. This is the clinical picture, 6 month. Patient has no complaints, good range of motion. And the patella movement is not more than a quadrant on the lateral side. So my take-home message is there are multiple etiology for recurrent patella instability. You have to do a thorough clinical and radiological evaluation to decide what treatment is suited for a particular patient. So every patient needs to be tailored according to the clinical and radiological findings. So there are multiple techniques to reconstruct MPFL and fix osteochondral fragments. You choose a technique which has enough medical evidence and what works best in your hand. Thank you.
So nice presentation, Dr. Ramakant. Dr. Joshi, what would you prefer, that the fiber wire for the repair osteochondral fragment or the vicryl?
I generally use the vicryl so that it absorbs. So this technique is also very good. So what we are doing nowadays, we are using a push lock anchors, which are biocomposite. So we put one anchor in the middle, and we put 2 or 3 fiber, the thick vicryls, and we put 2 anchors on the lateral edge, and the fragment is very much compressed like that. So this is also one of the technique. But as he said, whatever technique works best in your hand, you should do that. Patella is still probably an evolving joint, we think.
I think both observable and non-observable, they works well. I mean, the reports there is no difference as such.
The first dislocation was when she was 9 years old, because from 13 to 22, 9 years, the lady is 17 years when you did it.
It's 19 years.
Yeah, almost first dislocation at 9 years of age. And the osteochondral fracture, you're not sure that this is the happening from this time only, or
no, this happened this time because it was very painful and she had no complaints before that.
Oh yeah, because I was
yeah.
a bit worried about when this osteochondral fragment happened, and then going for a 9-year-old, we are going for
this was an acute episode in a recurrent condition.
Yeah, sure. That was my concern, because fixing old osteochondral fracture in a knee joint and what damage you can do. Anyway, very nicely done. Very good.
There has to be a clear message that you keep on prolonging, multiple dislocations have been taking place. So minimum after 3 surgical intervention should have been there so that multiple etiologies do not get involved. Is that right?
True.
Dr. Joshi, first time dislocator with the osteochondral fragment, would you like to do the MPFL on the same sitting, or you'll just come out with the repair and the plication of the medial tissue?
Means, the only indication for operating on first dislocator is basically if you have an osteochondral fragment. So if we are going to fix an osteochondral fragment, it is better to do an MPFL along with it, because we are taking the patient to OR. MPFL can be done, I think, in that. So that's our take, is that if we take the patient to OR for an osteochondral fragment, we do an MPFL along with it.
Wonderful presentation, doctor.
Thank you.
I am Dr. Rajkumar from Bangalore. I've got two questions for you. One is the point of fixation on the femoral side. That is the Shortall's point itself is in question and debate. This is the exact point where we need to fix. Your take on that, whether it is the Shortall's point or any isometric point that you want to use. Question number one, that is. The second question would be, is it required for us to use an implant to fix your grafts for the MPFL reconstruction, or we can use some dynamic structure that can help us to give us the same results as we use an implant?
As I said, I mean, there are multiple ways of fixing a MPFL. I mean, MPFL reconstruction. There are, I mean, techniques like basket weave techniques where you don't need an implant. So multiple techniques are reported. I mean, what suits best in your hand, you can do it. It's without implant, with implant, all are, I mean, everything is, I mean, all the studies they are saying that it's working great. So, I mean, it's you have to choose. I mean, I'm not saying that this technique is better than the other technique, but it works best in my hand.
Okay, what about
and
the
Shortall's point? I mean, I have chosen this point since so many years. It's working well. So, I mean, Dr. Rajiv, I mean, would you like to comment on this?
This Laprade article, now they are considering that it's an 8 mm area, which
Okay.
is important. So anywhere you are there, it's you are anatomical. So now when you test for your isometric point, it's not a one point, it's an area. So it's a 5 to 6 mm area that is important, and that is close to that point only. So it's very difficult sometimes to point on that particular point. The good thing is that take a true lateral view, and then I think
Yes,
Artex
yes,
is
yes.
having a very good scale. You
Yes.
can use that scale and you can point out in that area. But if you are 2 mm in front or back or like that, Laprade has shown in cadaveric study, it's a 6 to 8 millimeters area is there. If you are on that area, I think you are on isometric.
And you can always, I mean, check for the isometry. I mean, by putting a K wire, you can check for the isometry.
see
If it's
for
not
the
working, you can move a bit up and
So 2 or 3 millimeter you can move up and down.
Up and down, yeah.
By that way you can you can put it over the isometric point.
True.
Have you ever tried MQTFL?
That is, yeah, I got your point. I mean, medial patellar, transfer of medial patellar tendon to the medial collateral ligament, right? I have not used it, but it's mainly used in the immature patients. I mean, they are skeletally immature, and the results are good.
Thank you.
So it's a medial slip of quadriceps. You harvest
Yes,
it and you just
transfer
reverse
to
it.
the medial collateral.
The
yeah.
only issue is that the anatomical location of patella tendon is upper part of the equator of the patella. So you are there in the proximal part.
So it's
you are pulling it-
non-anatomical.
Yeah,
basically,
it's
it's
not
non-anatomical.
It's a non-anatomical
repair.
Or
so three issues are there. Something you have to take minimum 8 to 10 centimeter of the length of the tendon, and if you have a small length, don't try.
approximately you go all the way up to the I feel where the aponeurosis is.
Aponeurosis is there. And second important thing is that when you are planning for this, now you can use the suture anchor also. People are using suture anchor. So the concept of differential tensioning has come up. So you have two bands of MPFL. So one is tight in extension and another is tight in flexion. So you can tie this two band with the two threads in the putting your anchor over the shuttle point, and you can tie. And that by that way you can tie it with the adductor magnus tendon also in the same way. So just tie it with the vicryl adductor. So it's a medial stability which is important. So you can achieve by anyone. So well done, very good case.
Thank you. Fixing the femoral attachment, it should be in 30-degree flexion or 50 to 60-degree. Literature is varied.
Yes.
Some says 50 to 60 degree, some say 30-degree.
So
what's your take on
normally we fix it in 30 to 60 degree of flexion, and now if you are planning for a differential tensioning, so anterior band you have two bands, the superior and the inferior part. Superior part fixed in 30 degree of flexion, the inferior part fixed in 70 degree of flexion, so that you have differential tensioning of both of the band. So you have a superior band and you have inferior band.
Thank you. Yeah, that's very important. Don't over-constrain, over-tighten
That is
it.
important. See, patella should be mobile. So whenever you are tensioning it, your assistant try to pull it with full strength. So just take care that you should
Just
have a
hold the
mobile
patella.
patella. Otherwise, it will be a painful knee.
should be at the lateral border of the
Yes.
femur. It should not be on the medial side. It should be in fact on the lateral side.
Ask your assistant to hold the patella and the trochlear groove, just fill the, the borders, and then fix the femoral side. Thank you.
Thank you very much. It was well presented. So we have Dr. Arvind will be presenting the second case on the patella dislocation in pediatrics.
So mostly this patella dislocation patients are in pediatric age group. So this was in fact the 7-year male boy only, and this comes with the habitual dislocation of the patella. I think you all must have seen this 7 to 10 year of the patient with dislocation of the patella. And if you see the clinical presentation, you can see just at 20 degree of the knee flexion this get dislocated. And this was the X-ray of this patient. So Joshi sir, how do you approach in this 7-year male boy with almost every movement of the knee leads to dislocation of the patella?
It's a very difficult scenario in such a age group. So the minimum age that I have done something is I think 10-year-old. So investigate, see whether there is any alignment problem anywhere else.
So this was the MRI. So patella alta was there, and hardly there is any trochlea. It was completely flat. That's why this patient was having almost habitual dislocation of the patella. Rajiv sir, and this was the alignment view. So there was no hardly so much significant valgus was there. Yeah.
Some trochlea is there. Yeah.
You can say it,
It's
15.
almost flattened. Almost
yeah,
flattened.
almost flattened.
Okay.
10-15 degree of the angle.
Is there a history of first dislocation? What we know it was
So almost for last 2 to 3 years, he remember all the time he get flex his knee, there was dislocation as given by history given by his parents.
And by definition, if it dislocates by inflection or extension, it's habitual. So it's classical habitual dislocation.
All the time he flex, extend, this get at 20 degree of knee flexion, this get dislocated.
I think the standard principle we have to follow. The lateral release, medial plication, and trochleoplasty is plus minus for me because
so pediatric age group.
Yeah,
So in
I would, I would not go for a trochleoplasty at present. I would go for a medial plication, lateral release, and an MPFL reconstruction.
So in pediatric age group, you left with hardly any bony procedure. You have only option of soft tissue procedure. So in soft tissue procedure, you said lateral release,
Plication plus minus MPFL.
medial plication along with MPFL. So this is the patella. So how you will do your MPFL?
The depth of the patella, if you measure it will be at least 15 mm, 10 to 15 mm.
इंसाल सालवाटी रेशो उनका ज़्यादा लग रहा है इन्होंने रिकॉर्ड जो भी किया है
Just
ज़्यादा लग
pass the graft,
OT वाला वॉल्यूम कम कर दो बेटा. हाँ.
pass the graft, and on the opposite side of patella, that the double breasting of the graft can be done, so that will hold it.
Okay. The torsion was fine. CT film is not there, but torsion was fine. There you can see here also. The torsion was fine. CT film is not in record. APU lateral view and CT is missing in this presentation, but it was done. Torsion was fine. There was no problem. Patella alta was there. Yeah.
So I think extensive lateral release or a lengthening along with a medial plication generally does well. I have seen in pediatric group, if we can add a quadriceps tendon transfer also along with it.
We add in such type of cases rocks gold with procedure. Maybe today we'll see live also. So this is the I'll say the powerhouse for pediatric patella dislocation patients. And this was the this hardly in 30° this get dislocated, and as said by everyone, this is the lateral release that was done. So while doing lateral release, try to prevent cutting the capsule. Be with the, just like MPFL, medial patellofemoral ligament, on the lateral side they said there is lateral patellofemoral ligament. So release that ligament only, that is enough. Avoid cutting the capsule of the joint. So this will prevent the extra instability on the lateral side of in such type of cases if you are doing the lateral release. So this was the release on the lateral side from proximal to the distal till the patellar tibial tuberosity area. And this is the Rocks Goldwith procedure. We do almost in each pediatric patellar dislocation, in which you take the lateral half of the patellar tendon. It is just like a Fulkerson osteotomy in the adult, and take out this lateral half of the patellar tendon and retrieve it on the medial side. It is documented quite long time ago, and suture with this on the medial side with the periosteum here. Just doing these two till full flexion, it was not dislocating, maybe little bit further video.
Another option is lateral release and pesplasty also.
Yeah,
Sometimes
you can see this was not dislocating now. Yeah, this is the better view. And now about the MPFL reconstruction in this case, lot of things you can take the quadriceps tendon and then you stitch with the adductor tendon, or you can take the posterior adductor tendon around around 8 to 10 centimeter, and you take and then suture over the patella. All these options we have, but if you want to the real MPFL reconstruction, your isometry point will come almost at the level of physis. So that's the problem with pediatrics age group. So what we do, we take little bit distal here, somewhere here on the femur. So this way we correct this patella alta also, and at the same time as child grow, this will come somewhere here at the subtle point. We have follow-up of 8 years. The X-ray of that patient is not in this. So this is something we do usually. You take this subtle point from here to here, little bit distal on the lateral view here, and on this the two holes in the patella here. So this the gracilis tendon was used and drilled with 2.5 millimeter drill bit here, and that was passed here. This is 6 mm screw on the femoral side, and this was in the follow-up X-ray after 2 months. This patient was hyperlax also. There was hyperlaxity with this patient. This was after the 2. This patient said this me yesterday only X-ray of this patient. I called him, but radiologists there don't know, radio technician don't know the merchant view. That's why it was not here. So this is after 1 year, almost 1 year follow-up of this patient. थैंक यू. एनी क्वेश्चन प्लीज. हाँ ठीक है, इसके बाद OT पे लेंगे.
procedure for habitual dislocation in young children. So in that, basically, apart from root goals weight, they take a vastus medialis tendon and they make a tube below the patella to pull it medially.
That is Galeji procedure.
Galeji procedure. Along with that semitendinosis, tenodesis.
Yeah, before doing this MPFL, we used to do the Galeji procedure. But after doing this MPFL, hardly you need that Galeji procedure.
I think well done.
You know, you wanted to say something.
So I think the medial plication, you have different options are there. You can go for MPFL reconstruction, plasty also. So in pediatric age group, normally what the basket weave technique is very good because you don't put any implant close to the physis. So if you are dealing in the 7-8 years age group, so better tie it with the adductor magnus. I think the basket weave technique, and that is good.
That is also reported.
Implantless, almost you don't need any implant, and that gives a good medial stability also.
Right, your question, please.
Your voice is heard without mic also.
It's okay. Hello. A nice disposition of the case, and it's a great learning experience with the new old wine in a new bottle kind of a technique. And if you have to let us know, when does this trochlea develop completely? When do you have to do any bony procedures on the trochlea? Or is it required for the patella to sit on the trochlea for it to get molded?
So almost last 10 years we did only one tracheoplasty, and we must have done around 70-80 cases of patella dislocation till now. So in adult patient, we have this powerhouse of Fulkerson osteotomy that usually take care of everything. Complication with Fulkerson osteotomy, we had one almost impending compartment syndrome that we release every suture, everything next follow-up, next post-op round. So that was fully tense because of lot of bleeding at the osteotomy side. Other than Fulkerson osteotomy is very good. We did for lot of this chondral region in the patella, generalized chondral region in the patella patient also. In this we have that check X-ray also. But this tracheoplasty we did only one. There was very large bump that described is the cliff part, such type of lesion was there. So we did only one case. We don't have too much experience of this tracheoplasty. But believe me, we don't have any failure of this post Fulkerson and MPFL reconstruction.
I understand that. Now, like an analogy for the DDH, say for example, the hip is brought back into the acetabulum and then it stays there, the cup reforms. So like that, is it the same here when we bring back that small patella that you're seeing?
8-year follow-up, that patient, the trochlea hasn't changed too much, but it is staying, patella is staying over the patella. She don't have any history of that dislocation further. The same procedure was done in 2014-15, and now still she is doing fine. I don't find anything grooving in the trochlea in that patient.
So how many cases are there in your series?
In pediatrics, almost 5-6 cases we have. Okay. One of the patient, if Dr. Koslender is here, his case was that she was operated at the age of 6, now she is 16, 10-year follow-up, and he has recently saw that follow-up. In that case, the MPFL, no screw was used. MPFL was suture on the lateral side of the femur over the suture disc, and the suturing of the MPFL on the patella, just like in the last case of the Johnson, on the lateral border only. Hardly any implant was used in that case. And the similar case she is doing squatting, everything without any problem. So I'll say trochleoplasty may be a second chance surgery, as said by Joshi sir, because still the technique, fixation method and the selection of cases still vary, but again, some surgeon believe that if you are going to for surgery, you should be doing everything. So 6, 7 cases of such type of cases we have, starting from the age of 6 year. This patient is 7 year, from 6 year to this 14 year.
Okay, you see frequently these kind of patients. So if you want to formulate a proforma and tick those boxes saying that these are the things we need to examine in these patients, what would be those?
So first, hyperlaxity, because most of these patients are hyperlax. I'll say almost 100% of my patients are hyperlax, those who are having habitual dislocation of the patella. So, and that mostly are having trochlear dysplasia, hardly angle left with this for the trochlea. So these two are the most important factor, those who are having habitual dislocation of the patella. And remaining, as Rajiv sir will say about the evaluation of this patellar dislocation. So that should be done in each cases, particularly the valgus, and another thing is the rotational problem. Today our case of valgus is must be a, he has trauma in very early age group. Still he is 8-year-old child. That will be live surgery will be done. In fact, live surgery is also ready there. वहाँ ready है बेटा? जिसका लाइव हो रहा है, हाँ अभी वो है रेडी है तो शिफ्ट कर सकते हो क्योंकि
Okay,
दो
so Dr. Arvind, you have made justice to the basic fact that the basics, when they are used properly, howsoever grotesque displacement it might seem, it works. And you may have various ways to nail it. And you have done it the right way. Thank you very much.
Thank you, sir.
Now,
Are we going for?
Like in the hip. See, if you look at from 7 to 8 years or 8 to 10 years, there is a possibility that the trochlea can remold when once you bring the patella back onto the trochlea. That's why I was asking that question. There's a nice article in OJSM. I think if you get hands on that, it will be nice.
Okay. Okay, no worries. Dr. Raman, we will get you back on the after a few half an hour. So we are going for the live surgery. Is the OT ready? Bhushan. Hi. Good morning, Dr. Bhushan. Are you ready there?
I'll take about 5 minutes more. I'm just taking that loose body out arthroscopically.
We can continue
start
with that. You
showing
can tell us about it.
So, can someone show the pre-op X-rays and investigations?
I would like to invite the moderators for the live surgery sessions, Dr. Rajkumar Amra Bati sir, Dr. Ashish Kumar sir, and Dr. Manish Kumar sir.
थोड़ा पटला को नीचे करना आप जैसे पहले करे थे नहीं पुश डाउन मेरी तरफ बस बढ़िया बढ़िया अपनी को थोड़ा यस दैट्स बेटर दैट्स वो पकड़ेंगे आप 2 मिनट के लिए तो रिलैक्स ऑन पटला छोड़ दो पटला को तो अगर आप पटला को ऐसे लेके जाओगे आई कैन देन मूवमेंट शिवर एग्जैक्टली वेयर आई नीड टू गो आरएफ है अपने पास कुछ बोल सकते हैं खोल दीजिए
अरे फुल कट लीजिएगा डॉक्टर कॉटी फुल कट
मुझे निडल दे दीजिए एक वहाँ पे नाइफ दीजिए
So this case is female with mature, I think gained maturity with recurrent dislocation of the patella. In the X-ray, there is a loose body that must be osteochondral fragment from the patella. TTTG distance was I think 22. There is patella alta and there is mild grade of trochlear dysplasia in this case.
यहाँ पे उंगली को बंद कर दीजिए.
And valgus, there is no significant valgus at the knee joint.
Arvind, can you see the screen?
Yes, sir. It's quite visible here. The surgery is moderated by Dr. Rajkumar sir, Dr. Ashish sir, and Dr. Manish sir.
Okay, chalo. So first things, I've done a quick arthroscopy because this loose body was pretty visible. So let me see if I can fetch it out. ये आपका कैमरा वाले बंधु, ये आपका loose body निकल गया. The patella is slightly damaged, as you can see. I would ideally do a RF on this. If you are getting RF, I would love to use it. If you're not, then I'll just clean it with a shaver. So to take the loose body out, I've done a slightly bigger full cut है अपने पास?
Radio frequency है sir वहाँ पे.
Bhushan, good morning. Bhushan, can you hear?
Yeah, hello. I can hear you. बोलिए.
Rajkumar here. And if you could tell us.
बाइटर मिल सकते तो दे दीजिए. Possible है तो.
Bhushan.
दे रहा. Sorry, punch. मेरी भाषा गलत हो गई. So you can see the chondral damage to the patella. That loose body seemed to be quite chronic. So it has been removed, as you can see. I've done a superolateral portal to take out that area where the damage is. Patella को control करो. Hold the patella. Patella को steady रखो आप. I'm just cleaning a bit of loose bodies, loose tissue. On थोड़ा patella को आपकी तरफ लेके जाओ. Medial लेके जाओ. So the good thing about patella is it can be manipulated very easily. So what I'm trying to do is try and get grasp that area where the damage is. So the plan for this patient is going to be MPFL plus TT transfer. It's more than more than your medialization. What she needs is a distalization because the patella is not engaging. I would like to show you in a second once I take this piece off. So this is osteochondral, so it's not rather partly healed defect, so it's not coming easily. Patella को control करो बंधु आप. So give me the shaver again. So this will take a minute more, and after that we'll go back to our actual surgery in a second. Just give me a. Okay, so I've been told RF is ready, so we'll start using that in a second. So that's the patella inferior posterior margin, which is quite craggy or quite unhappy, as you can see. Patella को control करेंगे आप तो अच्छा होगा. So that's where the original section इस पर लगा दीजिए. Loose body has come out from. That's the original crater, as I call it. आपको पटेला को medial side को shift करना पड़ेगा थोड़ा सा. Perfect. So what I'm asking him to do is just show me the medial side of the patella, medialize the patella, so then I can easily clear the. So this is a cool cut device, so it doesn't heat that much, so it doesn't cause the cartilage to burn like the good old fashioned instruments that we used to have, where the cartilage used to become brown or black once you touched it. So this is more of ablation than burning. Still a bit of loose piece. I think that's from the original MPFL avulsion. All I'm doing is just stabilizing the cartilage if I can. ज़्यादा हो नहीं रहा है, but ठीक है, okay. Okay, that's fine. Okay, now let's assess where we are now. So you can see a decent looking trochlea. The patella, which is slightly uneven, that's because of the loose body that has come out. and this patella is sitting quite high up. So that's the position where the patella is. So we want to bring it slightly down so that it will start engaging early on. The rest of the knee joint is perfectly fine. Okay. I would like to show you the outside view if I can. ट्रोकार देना मुझे, ट्रोकार कैनुला निकाल के देना इसका. थोड़ा पानी निकाल देते हैं. Can you guys hear me or?
Yes, loud and clear.
Okay, wonderful. So all I'm doing is just taking some water off. ओके सो कैमरामैन बंधु ऊपर से दिखाएंगे यहाँ से एक मॉप दे दीजिए स्कोप बाजू रख दीजिए स्कोप अभी लगेगा नहीं 10 मिनट के लिए अपने को आधे घंटे के लिए सो दैट्स द मार्किंग ऑफ योर पटेला दैट्स द मार्किंग ऑफ योर tibial tubercle obviously you can see slightly lateralized can you see the screen
Yes, Bhushan, we can see.
so if I bend the knee you can see the patella tracking in a J shape manner I've marked the track so as it comes out straight it goes and engages in the trochlea. So it's like a J sign, not a classical J sign. But most important thing that you can see is this is the width of the patella, that's the width of the patellar tendon. So we are going to distalize the tibial tubercle, medialize slightly and do MPFL reconstruction as well. So let's start with a incision. Knife to me. So we'll do a combined incision for graft as well as for TT transfer. It's easier to do the TT transfer from the medial side because you can also and anteriorize the whole thing. So slightly big incision. Scissors, please. So unlike your normal graft harvest incision, this is a bit bigger and more towards midline because I want to access my tibial tubercle through the same incision.
Bhushan.
आपको शायद सामने से आना पड़े इनको कुछ दिखेगा नहीं यहाँ से Langenbein, give me a mop please. So if you can see from that side, that's my gracilis there. Light थोड़ा यहाँ से आ सकता है. Light यहाँ से आ सकता है. Rajkumar, Ashish boss, can you see anything?
Yes, now we can see. Great
So
adjustment.
that's your pace. Give me a 15 number blade. So what I'm doing is I'm holding the gracilis now. And I want to go just superior to that. I'm just going to release the pace anteriorly, superiorly. I hope I can show you a decent graft harvest here. यहाँ पे लगा दीजिए. So the first step will be to take a gracilis graft for your MPFL reconstruction. And after that we'll work on एक्स्ट्रा लगेगा तुमको एक कैट्स पॉ है सिस्टर अपने पास थोड़ा नहीं और बेंड कीजिए एडसन है अपने पास छोटा वाला I'll try and just take gracilis and not anything else. I need to release a bit more. I think it's a bit. 15 number blade है तो इस पर तो दे दीजिए मुझे. 15 number है आपके पास? So since your incision is too far to the midline, you generally struggle a bit to get the hamstring harvest. But that's the best of both worlds, other than making two different incisions. इसको निकाल दो इसको निकाल दो नीचे वाले दिखाइए आप So that's a good looking graft I've got. Ethibond number 5 है तो दे दीजिए. Ethibond number 5 to कोई भी चलेगा मुझे. Normally I'm accustomed to very thin graphs, but I'm impressed with the thickness of this graph. So let's see. So not many vincula. 15 number blade please. ये आप ले लीजिए यहाँ से वापस. ऐसा दिखाइए मुझे. इसके बाद में टेंडन स्ट्रिपर लगेगा अपने को. ले लीजिए वहाँ से. You can do it much more elegantly with a grasper, but it's all right. नहीं ठीक है हो गया. यहाँ पे एक आर्टर क्लिप लगा दो. बस. So unlike Semiti, grasses doesn't retract that much, but still, it's always better to be safe. So that's your gracilis. अब आप करेंगे पुकार. Thank you. So ग्राफ में सिर्फ पूरा निकाल के पूरा लेंथ ले लीजिए और दोनों तरफ से फाइबर वायर से सेंटर तक करना है. ठीक है. Okay. छोड़ दीजिए. So that's your graph preparation done. I'll just take a stitch in the pes fascia. इस पे वाइटल दे दीजिए मुझे अगर है तो. I'll need a diathermy अगर diathermy मिल सकता है तो. I'll come from that side now. मैं उस तरफ से आ रहा हूँ अभी 2 मिनट में. पटरी लगेगा अपने को. आप ऊपर से आ जाइए. So my aim is to now isolate my tibial tubercle, both from medial and lateral side, and to release the tissues. Now this is a procedure where I normally do a lateral release also. Now in this case it's a release. John sir is pulling my leg as usual. Give me an arter clip. Arter clip देना कोई भी. Third arter clip कोई भी चलेगा. So if you can see what I'm doing, I'm
I
just
think the
putting my.
cameraman is more onto your shoulder than onto the field. He has to make some adjustments to show us the images.
So that's my patellar tendon. If you can see that. Okay. नहीं दिख रहा है. चलो ठीक है. Okay. पैथर में आ गया. Thank you very much. चालू कर देंगे. कॉटरी चालू कर देंगे. So what I'm going to do is mark my osteotomy. I'll come from that side and do it. थोड़ा कम कर दीजिए. So I want at least 2 screws to fix.
Bhushan.
नीचे आ जाइए. हाँ.
The cameraman is
Good.
more onto your shoulder. We are seeing only your shoulders. And
My
less
shoulders
of
are
the
good
field.
looking.
Yeah,
It's
yeah,
fine, I understand.
handsome.
I understand. बंधु कुछ दिखाओ उनको. Anyway, I'm going to change my side in 1 second only. इस तरफ में. चलो, okay. This can go. I'll come from that side. आप यहाँ से दिखा सकते हैं. ए, mop नीचे गिरा. Just I'll need small Homan if you can give me, and saw whenever you got the saw. So if you can see what I've done, can you see it now? So that's the patellar tendon. That's your tibial tubercle.
No,
and
no.
I'm coming down all the way. I have enough space for 2 screws.
Dr. Bhushan, we just cannot see anything.
Oh, I'm so sorry.
It is just shaking and we cannot see anything you are showing so nicely.
So camera
कहाँ पे
person
दिख
has
रहा
to
है?
do some
TV पे कुछ दिख रहा है?
adjustment.
इनको क्या दिख रहा है? Can I show what they are seeing?
Right now we
थोड़ा-
see your incision, but he is shaking
नहीं?
too much.
Zoom out, please.
फोकस इधर ही है ना?
Little bit zoom out,
छोटे-
please.
ये हिप रिप्लेसमेंट वाले छोटे छोटे से वो नहीं करना है हमें. अच्छा, can you see what I'm showing?
Yes, right now we can see, but
अगर
asking
नहीं
not
दिख रहा
to
तो लाइट
shake
कम
too
करते
much.
हैं. थोड़ा लाइट थोड़ा यहाँ पे कर लीजिए.
Zoom out, please.
Yes. Can you see anything now?
Yes, we can see.
Okay, now let me just show what I've done till now. So I've isolated the patellar tendon.
Yeah.
Thank you, sister. So if you can see medial to lateral, that's my patellar tendon isolated. Can you see that?
Yes, we can see.
Okay. And now coming down, I have done a medial marking of my osteotomy. You'll see in a second.
Yes.
And I have marked the distal end also. Now this is the case where I will do a lateral release, as I said, because unless you do a lateral release, you can't mobilize the tibial tubercle.
Okay.
Scissors, dissecting scissors again. So what I'm going to do now is lateral release all the way to the joint level. Now this is the area where your tibial tubercle osteotomy usually gets stuck because of the ITB attachment. So I'm just releasing everything quite brutally on the lateral side. Okay, now let's take the saw. So you need to hold it there, like that, okay? एक ही चाहिए मुझे और एक लैंगन बैग से
Bhushan.
आपको मुझे या
Bhushan.
स्किन को प्रोटेक्ट करना. Yeah, go ahead.
There is a question from the floor. Do you do your lateral release in all the cases?
So when you are doing a TT transfer, you have to do a lateral release. And I'm not talking of lateral release and the patellar level. I'm talking lateral release distally. Otherwise, you will not be able to. That's a lovely saw I've got, very light. So आपको ये हाथ को नीचे करना है, if possible, और skin को protect करना है. So can you see what I'm doing? No.
Yes, not now. The cameraman has to be little stable. He is really unstable with his movements.
Land कर दीजिए उसको. ठीक है. So I've got my saw now. I'm going from anteromedial to
Bhushan sir,
posterolateral.
you don't
rather than doing
use
straight
any
like
K
that.
wire?
No, not just now. I'll show you what I'm doing and then I'll explain everything. So I'm just making my cut now.
Bhushan, Sudeep here. Can the camera zoom out and show us the angle at which your blade is going and the position of the leg as of now, so that we know what angle it is going, just to see, just for the audience and for me as well, how zoom out the camera so that he can show us the entire leg.
I've gone through on the lateral cortex.
Yeah, can
थोड़ा
you
ऊपर
stay
आएंगे
there?
अभी.
Can you stay with your blade there and ask the cameraman to zoom out so that we can see at what angle from medial to lateral you have gone?
Yeah, so I'm standing on the medial side of the patient.
Yeah, so the blade is coming from the medial side. Can the cameraman zoom out? Zoom out.
Okay. I'll take that back in a second. So now the key part of the procedure is to make the distal cut. So what I'm going to do now is mark my distal cut. That's the length of my tibial tubercle.
Approximately how much it will be, Bhushan?
I just want sufficient space to have 2 screws. So I don't want the old Ferguson way where it's a long tail and the big graft. You don't need that. Of course, that's my opinion. So एक गॉस पीस दे दीजिए मुझे. हाँ, मिल गया. Okay. So now that's my osteotomy done here. If you can see that.
Yeah. He was was initially zoomed out. Can he just zoom out again? He has just zoomed in. Can he zoom out? Zoom out कर सकते हैं? थोड़ा दूर कर सकते हैं?
Zoom out कर दीजिए.
और हाँ, ठीक है. Now we can see the angle at which the cut has been made. Nice. Okay. So it's roughly at 45 degree if I'm not wrong. So the angle would be around 45 degree, Bhushan, which the blade is going.
I need to make sure I'm all the way from medial to lateral side. And if I've done a decent job, this should lift off nicely. If it's not lifting off, I'll take my time to lift it because that's the important step during the surgery. I can't be using force on this. Now this is not completed, so saw back again. So minimum hammering, maximum work with your saw.
How much is the depth that you go distally?
So normally 5 millimeters is good enough for your screw.
Okay. 5 millimeters vertically you've gone and then angling it, you're cutting it.
So from here to here, anything between 5 to 10 millimeters is good enough. Anything more, I think it's the overkill. I'll just take a minute more. I know I'm wasting too much of time on this. Okay, let's try the osteotome again. So all I'm going to do is lever it up and not hammer significantly. So see the osteotomy moving nicely?
Where is the osteotome exiting? That's they want to know from the medial to where, which side?
Lateral side, completely
Lateral.
outside. So it's
It's
slightly
over the
posterolateral
anterolateral
area.
surface only.
I'll show you all in a second. Give me exactly 30 seconds to show. I'm releasing the fascia on top of the tibialis anterior because that is a very tough tissue and that usually holds the osteotomy intact. It won't allow me to lift it. See that?
Yes,
Are
very
you able to see
nice.
that? Okay, so that's a slightly thicker osteotomy for me, but it's all right. And this soft tissues need to be released. Now, what I'm going to do is lift off that osteotomy all the way to the, and you can see the tight lateral structures there, lateral tissues there. So I'm going to release that. Just I need a towel clip if you can give me. Now I've seen a lot of people doing this surgery even in live scenario where all they have done is this and just shifted it medially. Unfortunately, that doesn't work in my opinion. What you need to do is to physically lift off the osteotomy completely all the way to the infrapatellar fat pad, such as that. And when I hold it with the towel clip, I should be able to move the whole of the patella. Sorry, my glove got caught. So I'm still stuck on the lateral side. इसको छोड़ दो. ऐसे पकड़ो. ये अंदर, can you see inside here? So you have to take my word if you are not able to see. I'm
Yes.
getting stuck by some soft tissue, which is normally insertion of ITB from Gerdy's tubercle, which has extension to the anterior part. And I'm releasing that physically. The moment I release that, this will become fairly loose. See that? Can you see the fat pad underneath here?
Yes, it's a good release. Yep.
You need to release it completely, otherwise it's a half-done surgery. So it's like a half-baked bread. It doesn't taste nicely. So you need to release everything all the way so that you can move the tibial tubercle down along with your patella now. Okay, isko chhod do. So I'm able to move the patella down if you see that. And I'm still slightly tight, I feel, in a couple of areas. So it's a bit on the medial side that I'm going to release. यहाँ पे लगाओ. नहीं, थोड़ा ऊपर लगाओ. Remember I told you the lateral release? This is the lateral release that I was mentioning. If I don't do an infrapatellar lateral release, I will not be able to do anything. Now you're able to play whichever way you want with your osteotomy. Now what we are going to do is take a 5 mm section off from the distal part. So we'll need a saw back again. एक ऐसे पकड़ना, उससे आप पकड़ना पर you're right track. Sister, give me a scale. Give me the marking pen, please. So we have taken a complete cut, as you can see. So I'm going to take 5 mm from the tip, which is roughly there. So this much bone is going to come off completely, so that when I put my tibial tubercle back on, it will key into the original slot. And if you can see, I haven't done a U shape. It's more of a rectangular cut. It's always important to take the soft tissue out, otherwise it will just get entangled in your saw. आपको पकड़ना है, ये हिलता है. यहाँ पे उंगली रखिए आप. Can you see what I'm doing?
Yes, yes, you can go ahead, but yeah, we can see.
So that's 5 mm gone. See that? So
Yeah.
now when I fix it back, it will be 5 mm down. So my insal salvati ratio will be normalized and the patella will be pulled down. So इसको छोड़ देंगे अभी. यहाँ पे दिखाइए. Give me that. So can you see where the original cut is? थोड़ा अंदर आ जाइए. This was the original cut. What I'm going to do now is to push it down like that. So that's my tibial tubercle distalization. And that's one of the most important things that you have to do. I'm going to medialize as well. So I'm going to medialize by about 4 millimeters or 3 millimeters. And I'll show you how I calculate that. Now, if you can focus here, cameraman, can you see this much distance? Can you see that? I'm sorry if you can't see that. Can you see it?
Yes, we can see Bhushan. Yeah.
So this is the amount of medialization I've done. So I'm not happy with that, so I'll just do a bit more. And the mediation happens up north here, not here. So I'm pushing the tibial tubercle from there. Now, can you see how much I've medialized? That's
Yes.
almost 5 millimeters medialization and 5 millimeters distalization. Now, in reality, because of the curve of the blade, you take a couple of millimeters more. So I'll say 5 to 7 millimeters distalized and 5 millimeters medialized. That's your procedure essentially done. Sister, I need a K wire to hold this. There's a small fragment. We took off the fragment. Now I never put the screws in a same line. My screws are staggered. कोई भी K wire चलेगा temporary hold करने के लिए दे दो. उसके बाद में we'll need a 4.5 cc का guide wire. So this is a temporary K wire to hold. एक डायथर में लेके यहाँ पे कट करना है स्टेप. सिस्टर इसको क्लीन कर दीजिए टिप को. अब ले लो. So all this soft tissue tends to get entangled. So you need to make a mark on the periosteum so that soft tissue won't get entangled. So that's my osteotomy fixed. I'll just confirm whether I've medialized and I've distalized. Looks quite good. Let's get two. इतना ही किया चल ठीक है बात ठीक है ओके ठीक है चलेगा ओके लेट्स गेट द गाइड वायर फॉर सीसी स्क्रूज
By this time, I think your graft is ready.
Yeah.
Can you show us the graft on the screen, please?
Yeah, give it to me. I'll show the graft. So we just taken a gracilis. It's a thin, simple graft. But as I said, MPFL is more of a Chekrian ligament. Can you see the graft?
Yes.
So that's my MPFL graft. I know when I prepare the graft, I normally take my stitches all the way to the center. So I'm not only reinforcing the graft with the tissue as well as holding it firm, but this is a good way.
Yeah.
So let's put this back. Okay, we're waiting for the screws.
Bhushan sir, there is debate about this graft option, whether you should use the Semiti or gracilus.
So I think Semiti is for ACL. It's very rare you need to use Semiti for MPFL unless you're stuck and you don't get a gracilis when you're taking the graft. So I always go for gracilis.
Yeah, same
so I always
here.
Go for gracilis as a graft, yes. So we're just waiting for CC screws guide wire. Once we get that, we'll fix it with 2 screws, and that's done with your TT transfer, and then we'll do MPFL reconstruction.
What will be the minimum length of graft of your gracilus?
180 is good enough. You can stretch things and go to 160, but below that you're struggling. So theoretically speaking, if you want to physically measure the graft, that's the length of one limb, 80. That's the length of the second limb, 80. And that's the one in the middle. So 160, 180, and there'll be 2 in the joint. So 2 in the femur, which will be about 200. So 180 to 200 is a good length of graft in my opinion. Let's see if I can do a decent job of fixation here.
There is question regarding the reinforcement with fiber tape or fiber wire or ethibond.
You can indeed, but you don't want the graft to be causing any reaction. So yes,
And
you can
also,
reinforce with the fiber tape, but once again, it's a check rain. One more system, one more
yeah,
दे दीजिए, डेप्थ गेज दे दीजिए इसका.
this will make more stiff using fiber tape or
So
fiber
if it's
wire
too
with this
stiff,
MPFL
then you
gap.
are
Yeah,
going to have a significant knee pain medially.
yeah.
इसका डेप्थ गेज है सिस्टर, या दूसरा सेम लेंथ का वायर है जिसको 40 होगा, 40 से 45 होगा, विल यू कैन चेंज इट. इतना लंबा नहीं होना चाहिए. आई थिंक आई लेफ्ट 50 होगा शायद, देखो 45-50. सिस्टर अपने उस काउंटर सिंक है. So this is measuring about, will डेप्थ गेज है ना अपने पास, नॉर्मल डेप्थ गेज है अपने पास. चलो गिव मी अ वन मोर गाइड वायर दे दीजिए सिस्टर, वन मोर गाइड वायर दे दीजिए. विल फिजिकली मेजर द डेप्थ. हाँ जेंटा में डाल दीजिए. I'm sorry, I'm chatting with my team here, so we are making sure I don't forget to put gentamicin. Now, if you can see here, I don't want my screws in one line. The center is just a guide, just a K wire to hold it. So I want them staggered. If you put your screws staggered and not in single plane, chances of a fracture are very low. निकाल दो. Let's get the drill for this system. Cannulated drill.
Arvind, in your hand, most of the soft tissue procedures have worked. Still, there are a group of young surgeons here who would want to know whether the use of fiber tape, whether it is in ACL or your reinforcement techniques that you do, other than the extra-articular procedure, should we use it or should we not use it?
So, first time I used this fiber
डेप्थ
tape
गेज मिलेगा.
in 2014 only. That time fiber tape concept of imaging. I just came from Germany and there I saw they were using it.
46 काउंटर
That
सिंक है तो
chap
दे दीजिए,
was
नहीं तो छोड़ दो.
140 kg. Taekwondo player from Arunachal. Patient of one of my senior, Dr. Lenin. He is practicing there. He referred this patient to me. And I had no idea about the fixation of graft in
गाइड वायर दे
140
दीजिए.
kg male
गाइड
boy.
वायर दे दीजिए, जो अभी निकाला वो
So
गाइड
I
वायर दे दीजिए.
use first time fiber tape in that, and after 1 year almost, I use fiber tape again, in which I did this failed posterolateral corner reconstruction for ACL also and for posterolateral corner also. The case I presented yesterday only. So there is, I think there is some space for this very hyperlax patient in which already your ACL autograft collagen is compromised because of the property of the collagen in such type of patient for the graft, and also very obese patient. So, and those who
लंबा है,
having two
चेंज करना
time or
पड़ेगा.
three times revision ACL.
ड्रिल.
I never use this for the patella because I think MPFL is just a tissue. It's very thin tissue, hardly you can say the ligamentous part is there. In the dissection also, and all the dissector has say the same thing. So putting this fiber tape or fiber wire will make more stiff. We don't want stiffness at the level of patella.
आर्टरी
So
के दे
at the
दीजिए.
time of
वायर
fixation
निकाल
also,
दीजिए.
you had
ये
to be
दूसरा
very
वायर है ना.
careful. Thank you.
डेप्थ गेज दे दीजिए मुझे.
As far as fiber tape in ACL goes, I definitely can say that we have done a thesis 2000, I think 18 to 21, and like 4 years of follow-up is there, and 40 odd patients compared everything, and till date there have been no difference, any statistically or even a theoretical or a practical difference using a fiber tape in a routine
Right, zero.
ACL. And the graft diameter was also the same, almost the same. Groups were very
उल्टा डालना,
comparable,
हमेशा उल्टा
male,
डालना है.
female, age
Bone
wise,
going, no?
and of course these are all non-sporty
वहीं पीछे आर्टरी
population.
होता है.
So that's a disclaimer. Okay, they don't
Lateral
play
side
sports
होता है.
actively, so I don't know if they are a rugby player or a hockey player or a football player. how does a fiber tape will make a difference. But in a normal routine population that we operate here at Patna, his population is completely different, mine is completely different. So we didn't find any difference in any of the parameters for 4 years. And this is a 4 year, it's not 1 year or 6 months, 4 year period. And one more thing, recently I have operated
two revision ACL in which initially fiber tape was used. I have the video of that patient also. So
फ्लायर
now
दे दीजिए तो ये
in
दे
the
दीजिए
back
चलेगा.
of mind the concept is coming, really this fiber tape preventing the re-injury of ACL or not. In last 3 months I have operated two cases in which the primarily they have used fiber tape with the graft. Because
Arvind, I'm
in
sorry
young
I'm disturbing
generation
you,
surgeon,
but
this
that's my
tape is
medialization
giving
done.
the sense of relief
That's
for
my
them and they
digitalization
are
done.
using almost in every case now.
Arvind?
Sir.
Yes, Bhushan.
So that's my digitalization done.
Great,
And
sir.
that's my medialization done. So you can see it's come down by about 5 to 7 millimeters. It's come medially by about 5 to 7 millimeters. See that?
Dr. Bhushan sir, how you calculated middleization amount, that 5 mm?
So technically speaking, this is I've done randomly, but if you want to really be very clinical, you need to find your insult salvati ratio and calculate the new insult salvati ratio once you have uh, corrected the tibial tubercle. So can I get new gloves? My gloves are torn. Now, if you can look here, that's what my patella was, and now it's come down by that much. See that? So it's quite a sizable level I've got it down to. Marking pen दे दीजिए sister वापस एक बार. And now we'll start with the MPFL reconstruction. So I'm marking the medial border of the patella. Of course, patella position changes in flexion.
Yeah, one good tip was that, Bhusan sir, that I saw today, the screw is in different line.
Yeah, you
Initially
never put
we,
screws in the same line.
yeah,
Otherwise, you
but
can just split the tibial tubercle in half, especially if
yes,
you tighten the screw too much.
yeah, that may be one of the possibility. Thank you for that tips. But before that, we all were using all the screw, even 3 screw in all in same line.
Okay, let's do the MPFL now. So skin knife, normal skin knife. I'll need a 15 number blade after that. So what I'm doing is I'm making a dissection on the medial border of the patella, and that comes very close to your medial portal. Quite a few times I take the medial portal as well.
Bhushan, can the camera come from your right shoulder or left shoulder
Yes,
so that
yes.
we can,
I'm so sorry. I didn't realize that.
Yeah. He's coming
Camera वाले
from the
बंधु,
foot
मेरे
end.
पीछे से
If
आ
he
जाओ.
can come from behind.
आपको यहाँ से आना है. यहाँ से आना है. Sister, उनको जगह दे दीजिए. I need Addison's and I need 15 number plate. Got it? Addison दे दीजिए मुझे. Addison है तो दे दीजिए. सिस्टर एडिसन दिख रहा है छोटा पतला वाला क्लिप को सर केवल एक साइड दिखा कहाँ कैसे दिखा आपको मुझे दिखा ही नहीं इतना टाइम में क्या है थोड़ा नी को बेंड करके रखिए बस so it's a slightly bigger incision than I normally do but it will be easy for you, all of you to see. Now the most important thing in MPFL is the layer wise dissection. So you need to make sure you get the right layers.
Bhushan, if you can just slow
Yes, sir.
down, let the cameraman focus because this is the most
Yeah.
important part.
We are
and
not
we'll
able to
miss
see
it
because
actually. The dissection in the layers
sir.
will miss it. If
Okay.
he's still not able
No.
to focus, he's just adjusting himself.
Let him be
I
stable.
won't start, okay. So I've done a medial incision. There's nothing of importance here. I've
Right.
directly gone to the medial border of patella.
Yeah,
Can you see the medial border of the patella there?
very nicely visible.
Yeah,
Now
right.
you can,
Now can you show me the layers?
I'll show you the layers. Give me time. And 15 number blade, please. So there's a bit of fat I need to dissect first, and that happens due to your arthroscopy, that everything starts swelling up. Now, the best thing to do is go directly on the medial border of the patella. यहाँ से support करो एक हाथ से, बस thank you. All the way to the bone. And I'll tell you why. Because that is where you are going to fix your graft. And you need to find the medial border of patella, bony part. थोड़ा नीचे आ जाए आपका हाथ, बस थोड़ा सा नीचे, नहीं, not the knee, just नीचे. There's a small defect from the MPFL that is gone. So I need to lift my periosteum up so I can see where I'm going to put my graft in.
So that defect may be because of that osteochondral
Yes.
fragment that you have removed.
So that's my patellar periosteum, the superficial or anterior patellar periosteum. That's my width of the patella. Can you see the width?
Right, you can see.
Okay. So I'm just going to open the superomedial part. I'll show you in a second. Let me just take the soft tissue out of the way. And there's a lot of work done with a 15 number blade on this. Okay. Now what I'm going to do is take a small nibbler, just a small nibbler, and make a trough or a groove here for my graft to sit. What I don't want is the graft being prominent. आप ये हाथ को ऐसा करो, मुझे दिखेगा फिर.
Are you able to assess the anteroposterior width of the patella in this case? Approximately?
So it's about 12-13 millimeter. That's the width of the patella.
Okay,
So that's the width of the patella.
right.
Okay. So what I'm going to do is that's perfect. This is exactly what I wanted. So I'm releasing making a trough on the medial border of the patella. This is important because my anchors are going to go. Let's get two anchors, bandhus. Kidhar gaya? 2.8 millimeter anchors. So I'm now going to put two anchors. Now, marking pen dena.
And preferably, what would be the distance between the two anchors?
Swirl lock nahi chahiye. So this is the superior border of patella. This is the inferior border of patella. That's the equator. My entry point has to be at the level of equator or above. So I'm going to put two anchors, both going from superomedial to inferolateral along the, this is exactly what I want. So
The preferable distance between those two anchors.
1 to 1.5 centimeters, bigger patients 2 centimeters.
Okay.
So since I've done my trough, it should go easily with the hand. And I should start getting a good feel of the anchor holding. So I don't know whether you can hear it, but I can feel a nice tuck, 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 which is sign that I got decent purchase. And I'm using the maximum length of the patella. Hammer to me, thank you. So I'm putting it diagonally. My fault. Along the diameter of the patella, but oblique diameter. Now that's my second anchor. This is the tricky part where you can easily go in the joint and rake the joint completely. That's why you need to go more towards the dorsal cortex.
Do you aim
that's
to
my
converge
both the
anchors?
anchors. So that's my both anchors in. Now this is where my patella hold is going to be.
Bhushan, do you aim to converge these anchors?
No, they have to be parallel like
they
that.
have to be parallel, okay.
Yeah, you can converge, but I normally say that I purposely do it when it happens, but I don't really want to. Okay, now the fun part is the layers. So आप इसको छोड़ दीजिए.
So one is at the equator and one is at the just below the superior pole.
Dissecting scissor system. So that's layer number 1. See that? Can you see that?
Okay, yes, we can see.
That's first layer. That's layer number 2.
Right.
And the deeper inside is the synovial layer, that's layer number 3.
Okay.
You have to go between layer 2 and 3 and make a tunnel there. Quite a few times the synovial layer is very flimsy and you end up coming in the joint at the latter part or so that's my tunnel done. Can you see that?
Yes.
Okay, so I'm just going to leave my scissors there for a second while I make my second incision, which will be somewhere in this region only. Now, for this knife, please. For this, we are going to use our shuttle point guide. निकाल दो उसको, निकाल दो उसको, चलेगा, बस. Originally, I should do it percutaneously through a half a centimeter hole, but once the screw got lost in the back of the knee, and since then I realized it's not worth doing that. So let's get a ethibond number 5, sister. The same that we use for the graft. Can you see what I've done?
Yes.
So, and as you can see, there is no fluid coming out. So I haven't violated the joint yet. Take the needle off. Needle cut kar lijiye isko. खींच लो बस छोड़. So that's my first ethibond, which is going to be important in getting the graph down. Okay, all clear so far? Let's get the X-ray now. C-arm, I want a lateral view for the C-arm bandhus. Time.
Bhushan,
MPFL stick
Bhushan,
खोला आपने? Yes, go ahead.
I asked this question in the morning also, and now I'm asking you also again. Is it always the shuttle's point, or is there any isometric point that you want to use for each patient differently?
No, so the radiological point is fairly fixed, but if you want to know the bony landmarks, you have to find the adductor tubercle and you need to go 8 millimeter distal and 5 millimeter anterior to that point. I know it's a very vague thing because these are all designed for Caucasian males, so we can't replicate that in the Indian population. But roughly speaking, you need to be between the adductor tubercle, the medial epicondyle, and the gastroc tubercle, which are easily palpable landmarks here. So I can, where my finger is, that's the adductor tubercle. Where my finger is now, that's the medial epicondyle. And where my finger is now, that's the gastroc tubercle. If you are between these 3 points, or then you are generally well sorted. Open करना है इसको. Waste हो जाएगा आपका पूरा. But waste हो जाएगा ना पूरा. छोड़ दो. We'll do it without it.
Rajkumar sir, your take, you have asked twice this question. What you do?
I'll show you what I'm doing. I don't use the lateral चाहिए. थोड़ा पीछे हो जाइए. मुझे स्पेड टिप का बीच पिन है तो दे दीजिए. स्पेड टिप वाला. नहीं स्पेड वाला इसके एंड में जो स्पेड होता है ना डायमंड शेप बोलते हैं उसको. So now the first and most important thing is to get a true lateral view. पकड़ा है? So I want to get a true lateral view and then I'll show you where the point is. So you can see the TT transfer done nicely. You can see the position of the anchors nicely. So आपको थोड़ा ऊपर जाना है, थोड़ा सा ऊपर जाना है. बस दिखाइए अभी. दिखाइए. So I want a slightly better view again. दिखाइए. दिखाइए. Again. Okay, so I'm not perfectly lateral. आपको इसको नीचे लाना है, इसको ऊपर करना है थोड़ा सा. Tilt, बस. दिखाइए, बस.
What would be your perfect lateral view, Bhushan, when you are
Where
satisfied?
both the condyles are perfectly superimposed. Anterior posterior cortex is superimposed. दिखाइए. नहीं, opposite करना है. दिखाइए. Okay, उल्टा कीजिए. इसको ऊपर, इसको नीचे कीजिए. और ऊपर जाइए. और थोड़ा कीजिए. बस, अभी जाइए ऊपर. बस दिखाइए. Yeah, so see that's the true lateral view. Both the guide wire दे दीजिए मुझे. लोड करके दे दीजिए. नहीं है, ठीक है. नॉर्मल दे दीजिए, चलेगा. I'll need a 4.5 as well. So the width of the patella that you see is the central part. So on the medial side, the patella becomes quite narrowed or thin. So you should not be looking at the center of the patella there. X-ray, please. So that's slightly more anterior. So if you see the Blumenstadt's line, can someone show the Blumenstadt's line? You know the Blumenstadt's line. And you can see the posterior cortical line. So if I go between the two and slightly proximal, X-ray, please. And slightly more posterior window. X-ray again. Okay. थोड़ा ऐसा कीजिए पैर को. X-ray again. So that's where my Shortle's point is. Okay, everybody agrees? Anybody has a different thought? They can.
Looks okay, Bhushan. It looks perfect from the previous image. It's good.
I was worried when you say it's okay.
नहीं ठीक है भाई. You are in the battlefield. अभी तेरे को ज़्यादा ठीक से दिखता है. हम लोग यहाँ पे पेरीफेरी में हैं. ठीक है. It's good. It's looking good. Yeah.
This is 4.5 now. X-ray again. So that's my drill completely through. So I've come out on the medial side. If you can show the outside, I've come out completely on the medial side. So
Bhushan sir.
I will take about 10 minutes more.
Yes sir.
for the
One
surgery.
question. Dr. Bhushan.
Yes, go ahead, go ahead.
Yes. Would you comment upon the position of the patella at present?
I'll tell you in a second.
Is it a bit Baha?
Slightly Baha, I agree.
Okay.
But the patella is quite stable now. Now, if you remember our theory,
Yeah.
in 30 degrees of flexion, the Blumenstadt's line should cross the superior two-third and inferior one-third of patella, which is perfect here.
Okay.
Can you see? If you just extrapolate the Blumenstadt's line,
Right.
it's cutting the patella between superior two-third and inferior one-third. So I feel this is all right.
Okay.
So if you look at the Blumenstadt line, this is all right. And when I extend, the patella goes up. So 7 millimeters or 6. Screw कौन सा है? 6 या 7 कौन सा अपने पास? Now 6 by 20, 6 by 23 चाहिए screw. और मुझे 6 मिनट का drill दे दीजिए. So now I've done a 4.5 drill. So my sutures can pass easily. Sorry. नहीं 6 का दे दो यार. ग्राफ भी है ना. Why break it? 6 का दे दो. I'll just do cortex, बाकी कुछ नहीं. Deep नहीं जाऊंगा. So 623 screw we are going to use for the.
Sir, the operative side, cameraman, the operative side. If you have got two cameras, you can show both at the same time.
I'll need a nitinol wire system now. इस पे screw जाएगा. Ethibond, one more Ethibond sister. So all that is required now is to just pass the graft inside and fix it. But I would like to show you how the graft looks from the joint at the end of the arthroscopy also, at the end with an arthroscopy also. So this extra synovial position of the graft is very important. Okay, आप खींच सकते हैं वहां से. एक बार वापस आ जाइए एक्सरे के लिए सर. बस दिखाइए. I always take this X-ray just to confirm that my nitinol wire is in the tunnel. That's done. अभी सियाम ऊपर जा सकता है या निकाल सकते हैं, चलेगा. निकाल, हटा, निकाल दो. So now let's put the graft in, and we're almost done with the surgery then. Okay, lying in back. यहाँ से पकड़िए आप. Lying in back. वहाँ से पकड़िए. System मेयोनिडल लगेगा अपने को. Now, if you remember, I made a nice trough. Graft दे दीजिए. I made a really nice trough on the medial side. So my graft will physically sit inside the trough. So I mark the central point of the graft. एक marking pen दे दीजिए. Okay, so that's the center part of the graft for me. Now what I'm going to do is 5 more minutes, 5-7 minutes more. इसको उंगली रखो इसके ऊपर प्लीज. ऐसा पकड़ो ग्राफ को आप. So I'm just going to tie the knots of my anchor, and that's going to bury the graft on the medial side. So there's physically going to be healing of the graft to the bone. Okay, इसको. Tunnel has been done, so everything has been done. Just passing the graft now. Just passing the graft. And then quick scopy to see. Closure दिखाने की जरूरत नहीं है इनको. I'll take a Mayo needle. Now, this is originally technique by Shottle, later modified by Sonori Cote. I have modified that a bit. Mayo needle लगेगा अपने को. So I have modified that technique over last 8 years. What I would be doing, I like to transfix the graft. So in case my bone is weak and my anchors fail, I still have a good purchase in the patellar periosteum and synovium. I'll show you what I'm doing. अभी निकाल दूंगी हो गया.
Any possibilities of the graft getting cut through using these 5 wires?
Unlikely.
Okay.
Because it's a really decent graft I have got.
Bhushan, you have used your anchors here, that is fine. Some people have the habit of drilling the patella.
So I think in that, there's a higher chance of fracture. If you are making a tunnel in the patella, because anything which is continuous in a V shape or a central position or a vertical tunnel is going to have a higher risk of problem. As I told you, we are replicating the anatomy as much as possible. So when I say I'm replicating the anatomy, I want the original footprint of the MPFL to be simulated or emulated. So
Were there any incidents in your case where you had a fracture through the tunnels, and how did you manage them?
no, unfortunately, or fortunately, no. I've published my series of about some 70 odd MPFL reconstruction with 3-year follow-up without any complications as such. I always used to say that whenever someone says no complication, you should take it with a pinch of salt. But luckily for me, it has been true. So I haven't had any fractures, but I have been referred a couple of patients from outside where there was a proper fracture through a vertical tunnel, knife 50 number, a vertical tunnel and a transverse tunnel as well. So you need to be a bit careful when that happens. So if you see what I'm doing, I'm taking a stitch through the patellar periosteum, which is a very strong periosteum, and transfixing the graft at the same time. So you can call this as a technique of medial tensioning for my patients if you want to.
So
I'm going
Rajkumar
through
sir,
the graft.
so about the fracture of the tunnel in the patella. So if you see this gracilis, this is hardly 3 to 3.5 millimeter only. And if you are putting the swivel lock, that is usually 4.5 millimeter or 5.5 millimeter. So that much of the drill you have to do in the patella. So if you are doing only 3.5 millimeter, you can pass your graft through the patella. You can just knot the end of the graft on the lateral side of the patella. So in that case, you don't need any extra implant also. At the same time, the tunnel in the patella is very small. It's 3.5 only. That we are doing practice at our center. So hardly any chance of fracture in such type of.
I have fractured one.
Yeah,
With the
it's
same diameter, with the same things, if you drill two tunnels in the patella, then it got fractured in my one case. And when I had to repair that patella, at that time I have to even put some graft for those tunnels. It was difficult because exact contact between the two portions
fracture part
was having a gap.
gap was
So I
there.
had to graft it and then do it. So it does happen. Not a very good method of drilling through and through patella, the two tunnels and the 4 millimeter reamer you get
Not
for
4
the ACL.
millimeter. It's you
Yeah.
do with either 3.5 or 3.2. That is the diameter of your gracilis tendon. You
That,
don't need to drill with the 4.5
but
millimeter
normally
only.
people do with the 4 millimeter
Yeah,
reamer that is
it's
provided for the ACL.
yes,
So
yes.
that's why it happens at times.
Now I'm just passing the graft, just tying a knot on the graft so there won't be any jumbling of which side, which graft has which suture belongs to which one. So simple graft passage now.
So when you use
Kiss it,
swivel
kiss it.
lock and when you use anchor,
I'm sorry?
so any
I
advantage
didn't get the...
you get when you do swivel lock than
The
anchor?
swell locks are very good to get the graft in the bone. Now, if you remember our discussion, what we said, निकाल दो पूरा, खींच लो, खींच लो, खींच लो, पूरा खींच लो, हाँ. So hold this ऊपर, इसको पकड़ो. Trying to separate them, make sure none of them are through the other. Otherwise, my graft goes. Okay. So you need to make sure the
When we
graft is not
use
crossing.
swivel
So
lock, then normally we don't
that's my
make this
grafting.
trough. We just make half holes, put the free ends of the graft into that. So that's a different technique altogether. It's not like
खींच
this.
लो. So now the graft is going in, as you can see. खींच लो, खींच लो, खींच लो, मेरा उंगली बीच में है. चलो. Now you need to just pull it out. खींच लो. See the graft gone in now? Okay.
Yes.
So I'll show you the graft. That's your MPFL graft here. Toothpaste दे दीजिए मुझे. Addison दे दीजिए. That's my MPFL graft here. See that? And I don't want it to be too tight. So let's get the screw, 6 by 23, whatever.
What is the angle of the limb that you're keeping
Uh,
and you're trying to
30
fix your,
degrees of flexion
yes?
with patella on the lateral trochlea. So the patella should not be pulled in. Aram sir. Patella should be held there. So on the lateral part of the trochlea, so pre-subluxation level. So you do not tighten it or pull it to the medial side. It is either held in center or slightly lateralized.
Do you check intra-articularly also before you fully tighten your screws onto the lateral side of the, on the medial side of the femur,
So normally
arthroscopically, through a range
I
of
do a
movement?
scopy. I do a scopy at the end once I finish the. मैं ज़्यादा मत खींचना, थोड़ा पैर को ऐसा रखना, तो थोड़ा खींच लो, बस. I normally use a titanium screw,
It's
so
a
I can
6
see
mm
on the
screw.
X-ray whether I'm perfectly in or not.
6
But
mm screw, Bhushan.
623, yeah.
And knees at 30 degrees flexion.
Yeah, and patella center or slightly lateralized. That looks quite good. I'm happy with my screw gone in. So I'll leave the guide wire in. And let's look in the joint now. Leave the guide wire in. Leave the guide wire in. So let's look in the joint now. Make sure we've done a decent job.
Bhushan, there is a question from the floor.
Yeah.
How
So
sure are
can
you that you have not over-tightened the patella?
So if I'm able to put my scope in the joint, then you are fine. If you struggle to get the scope in the patellofemoral joint, that means you have over tightened it. And when you flex the knee, the graft becomes slightly tight. So when you flex, if you are struggling to feel the tension which is too much, if you are struggling to bend the knee, then I think you should be worried that you are over tensioning the graft.
And also your lateral border of the patella should be matches with the lateral border of the femoral condyle. It should
That means
not
you
be,
centralize the patella,
yeah.
not medialize the patella. Okay, let's see where we are.
But then if you have put in the screw and you feel that you are tight, do you have the margin of error? Can you really
Yes, you
revisit
can
and
still
revise
do
it?
it. You can
With
take
the
it
peak
off and
with the
redo
real
the whole
level
thing.
screws?
Now I should see my MPFL somewhere here. So that's my MPFL. If you can see the V-shaped structure, that's the lower part. That's on the femur. That's up going all the way to the patella. Can you see those V? That V?
Yes, we can see Bhushan.
So that's extra synovial. That's going all the way to the patella. I'm just turning my light source to see the whole width of the MPFL, attaching to the patella, going down to the femur, extra synovial between layer 2 and 3. See the damage that's happened due to the dislocation in the patient. But now with both these things, I should get my patella fairly central. You see the patella moving really nicely now.
Can you visualize from the superior portals and then show us the tracking of the
I
patella
haven't
is
done a
okay?
superior portal. If you, I have done a superior portal. My fault.
You have done, yeah.
I have. Sorry, I forgot all about it. But I don't do it that often. This was because of the loose body. Let me see if I can show you anything from there. Okay, so that's in full extension. Now, actually, it's a good idea. So in full extension, you can see the patella is already starting to engage. Half of the patella or 1/3 of the patella is up, lower part is getting engaged. And I don't know whether you can appreciate what I'm doing, but see the patella getting tracked in centrally. There's no J movement of the patella happening now. That's the screw that's the thread which has come out. We're going to cut that, don't worry.
Yeah, it's good.
Okay, so let's see that again. See the patella and see the trochlea now.
Yeah, it's looking better than the previous one when you're removing the loose body. Yeah,
So
it
that
looks
looks
good.
quite good.
Yeah.
So it's stable now, it won't come out. I'll cut that suture off, and then I think we're done. Okay? think
There is
we're
a
done. Thank
question
you.
from Dr. Ashish for you, Bhushan.
Yeah.
Till what range of knee movement you will do and flex the knee and see to say that the patella is stable?
So the moment the patella engages, that's about 30 to 45 degrees. You don't need to do anything more. Knife, I guess.
Yeah.
So beyond that, you don't need to worry because the patella is already engaging.
Okay. Now, since you have moved 20 to 45 degrees, now your scope is out, your all guide pin, everything you have removed now. And during your range of movement, if you hear the squeaking of the patella, what will be your inference?
Too tight, that
Yep.
happens. So if you're squeaking, that means the patella is physically protesting when you're bending the knee. Then you are slightly worried that you have over tightened it, and then you need to loosen the graft a bit. You can still undo the screw and do it again. Now remember that layer wise thing I had said.
Yes.
We are going to close the layer on top so that my graft is not seen. So whatever pap I have done here is completely covered. So nothing will be seen inside. So the one thing which I don't like is any graft which is in contact with skin, any metalwork in contact with the skin. So even when I'm doing a HTO also, I make sure I cover my implants completely, because I feel if it's in contact with skin, you have a high chance of adhesions there. So that's just a couple of stitches I need to take, and then is the skin, that's all. So if you can see what I'm doing, you can't see the graft anymore. See that?
Yes, Bhushan.
That's your MPFL and TT transfer done. Can we sign off? Any more questions?
There is a round of applause for you from the floor
Thank
here
you.
for the wonderful case. Thank you so much, Bhushan, and we'll be switching over to the next OT. Thank you
Thank
for
you very
your
much.
great skills and the disposition of the case. Thank you so much.
चलो, आप close कर लोगे?
So,
पक्का कर लोगे ना?
are you guys there?
Sir, good morning, sir.
Hello?
We are still there. Dr. Rajkumar and
Okay.
Dr. Ashish here
Hi,
will be chairing your
good
session.
morning. Okay, so this is a 8.5-year-old girl who has a severe valgus deformity of her knee. Okay,
चलो, close कर लो.
okay, and we focus on the x-rays.
इसको करना है.
Okay, we can first focus clinically. Okay, so udhar se the camera dikhao.
Thank you, sister.
So you can see the severe deformity. Can you see that?
आ जाओ, आ जाओ.
So not now.
Nahi. Adesh. Okay.
Sister, आइए आप भी.
Yes, we can see the patient.
Okay, so and when you flex the knee, the patella is tending to go out laterally.
We cannot
okay?
see that. We cannot see.
Thumbs up.
Yeah.
Can you focus from there?
Yeah, light is
So
too
just-
much. Some reduce the light. a
Light,
little.
light band kar do na thoda. Any better?
Yeah, it's okay.
Okay, so now you can see
चलो, आ जाओ, आ
as I'm
Yes, आ जाओ.
going there, you can see the patella is going out here.
Yes, we can appreciate.
Okay?
Thank you. अरे,
Yeah?
और एक बार, चलो आ जाओ.
Is that clear or not?
Yes, it's clear, sir.
Okay, fine. Okay, so you can see that when I'm straightening it, the patella is coming back somewhat into place. But as I'm flexing it, it's going out. You can see there's a severe deformity. X-rays. Can you focus on the X-rays?
This is the best way of doing it. कितना super दिख रहा है देख. ऊपर
So
है,
the
अच्छा,
history
triangle,
is
सब अच्छा.
this child had some chest infection when she was about 5 or 6 months old. At that time, they did not, I mean, she was quite seriously
Camera
ill for
person,
some
kindly
time, but-
focus on the view box, please, on the X-ray. Yes.
Yes,
Okay,
now we
so
can see.
she was, at that stage, they did not notice any infection in the limbs or joints, etc. And then she recovered from that, and the parents did not notice anything till about a year and a half ago. Okay, so a year and a half ago, they noticed that the knee right side was quite deformed, and this was progressively increasing, and the patella was gradually going on to the side when she was flexing her knee. Okay?
sir.
So can you see the x-rays clearly?
Yes, we can see.
So
What
if you
about
see
the
the
total
AP
length of the femur? Both are the same on either side.
Pardon?
At least on the medial side, if you measure, the femur are the same length or some shortening?
No, if you see the pelvis, it's tilted.
Yes, sir.
Yeah, so there's some shortening.
Okay.
So the other thing is, if you look at the AP X-ray, there's a physial bar which extends almost till more than 32% of the width of the physis.
Sir.
Okay?
Sir.
The MRI measurement says around 25%, but if you look at it on the X-ray, it seems more. The other thing is the severe deformity and so the options at this age are things like growth modulation, but because she's already got a patella problem with the patella sitting out and the severe deformity, we plan to correct the deformity, then see what happens to the patella. And if the patella is still maltracking, then we'll do a Roux Goldthwait procedure for the distalization. And if it is still not okay, then we might need to do an MPFL at the same time. Okay?
Sir.
But hopefully, once we correct the deformity, the patella will sit okay, in which case that's all we need to do. And the plan is to do an opening wedge because we don't want to compromise the length anymore. So we'll gain some length, but she might still be a bit short. That we can deal with once she attains skeletal maturity.
Can we see the MRI, the trochlea also, a little bit?
Yeah, the trochlea. So, but again, she's 8.5, so it's a bit early to do anything to that. Yeah.
Not to do, but just to see. We just want to see.
Yeah, definitely. There's trochlear dysplasia. You can see that. But then because the patella is out, the trochlea is not going to develop.
Okay.
Okay? So it's like the chicken and the egg. So it's like the hip, dysplastic hip. If the hip sits in, then hopefully it will remodel. Okay?
Sir.
Any other questions before we start?
Oh, nothing, sir. Please go ahead.
Okay, so anesthetist ready? Checklist done? Huh? Kisne kiya? Okay, so the checklist. So this is another thing one should get into a habit of, is doing this pre-operative checklist before there's a timeout before you start the incision.
The cameraman, can you come from the
all of you
opposite
must be
side?
aware
The
of it, but
cameraman.
not everyone does it, okay? So it's important that one gets into the habit of doing it. Okay,
sir,
so-
John sir,
Sir, the camera-
ask the camera person to come from your shoulder side.
Yeah, idhar se aa jao.
He is just standing on the medial side, has to come
Yeah,
on
I
the
know,
lateral side.
typical. देख के उधर टच मत करोगे.
So you have used tourniquet, sir?
Yeah, we've just inflated the tourniquet. Okay, so we'll get started. We're going to do a lateral incision.
Still, camera is not very clear, sir.
Camera. From your shoulder, front side, sir.
अब देख सक रहे हो? Any better?
Little bit clear, but still need to be focused more. Now it's better.
Now it's okay.
Okay, tell me when it's okay, then I'll start.
Yeah, it looks okay, but light has to be
Light थोड़ा सा कम कर दो ना, उधर कर दो थोड़ा.
because lining is coming there. Yeah, it looks
Now?
better now. Yeah,
Yeah, I can manage with this much light. It's okay.
yeah.
मैंने थोड़ा दूरी रखो ना उसको. उसको इधर से दूर रख लो ना. हाँ, I don't need more light.
Yeah, it's
That's
look
good, huh?
good, sir. No, it's good. now.
Okay, fine. So we'll just start with the incision, which we just straight incision. We'll leave it till the condyle at the moment. If we need to extend it for the patella, we'll extend it on, okay?
Sir.
Again, light lining is coming on a screen here.
Again?
Yeah, we can.
Light मत डालो ना यहाँ कितना बार बोलेगा?
No, it's fine. It's
Yeah,
perfect
they
now.
keep हम बोलेंगे ना तभी कुछ करोगे, हाँ? Okay, so that's the fascia lata. Okay?
Yes, sir.
So what we do here is usually do a true lateral approach.
Sir.
Retract band. So we will divide the fascia lata laterally and then take the entire quadriceps muscle off the septum, yeah? So as we're going here,
Light need to be focused and glare has to be little bit less.
Glare है sir थोड़ा.
एक लाइट को थोड़ा तुम हटा दो ना यहाँ से. अच्छा, they're changing the camera. Let's hope that's better. Yeah.
Yeah,
Arvind,
it's better.
can you see now?
Yeah, it's better, sir. Little bit zoom less zoom. zoom out.
Zoom.
Yeah, it's this. Yeah, this is perfect, sir.
इसको करो ना, कर रहे हो तो हट जाओ, हट जाओ.
We can see the IT band.
Okay, so you can see that very clearly. And we're going to just take the whole quadriceps off the lateral septum, yeah? I might need a bit more light at some stage, but
Camera has to focus on the knife only, because this get hampering with, yeah. Yeah.
retract here. Okay. I'll just divide this here. You have to be careful not to go behind the septum.
Sir.
We're going to take this up, so it's going to be part of our lateral. Retract the muscle now. Can you see okay?
Sir, we can see. It's all good.
Okay, I might have to change the light a bit at some stage because it's dark for us, but we'll see. As long as we can manage, we'll. So you can see now the lateral intermuscular septum here.
Sir.
Yeah? Can you see the lateral septum?
Yes, sir.
Okay, so we are taking, so what we'll do is we'll just take the muscle off. Can you hold it? So, so you don't actually have any significant bleeders. And then
Sir.
you go right down to the bone. So we are right down to the bone here. Okay. So there's one vessel coming there. We'll see if we need to tie that or not. Lever. Knife. It's okay, don't worry. Don't worry about it. Don't be. There'll be a few bleeders here that you just coagulate. That's okay. Vessel there, catch it. Catch this vessel now. Yeah. It's not working. Okay. So we're going to take this a little more anteriorly here. Come on, guys. Lever. So, okay, so now we're going to check the C-arm to see the, so we're getting to the area of the condyle here. So, we'll strip the periosteum only in the area where we need to do the osteotomy, okay? Rest of it will be extra periosteal. So, we'll probably do an oblique opening wedge osteotomy without graft, okay? With a young child, I would expect it to heal. To be careful of the linea aspera that you, where the periosteum is quite thick. Okay, so we go across and then it's easy across the other side, yeah? See that?
Yes, sir.
I'm behind the femur there.
Yeah, we are seeing it.
Okay, and then I'm front, we just go, again we'll take off the periosteum in this part. Image, this should take this off. Just leave one for other mark. Artery forceps. So we'll mark out where we start an osteotomy and we'll be heading towards the growth plate obliquely. So I think that should be about right. Maybe a couple.
Okay, so considering
few
this
millimeters below.
deformity, so what should be the starting point of the ostomy?
So you tell me what you would do as your starting point of your osteotomy.
I would be in the metaphyseal area, sir.
No, so I want to end it up in the physeal area. I want to be away from the physis.
Right.
Okay? So you need to work out, and you want to be roughly parallel to the joint line. So it's oblique, and then we'll straighten it out and hopefully keep the lateral cortex intact. We can do biplanar, but this bone is so thin that I'm just going to go in one plane, yeah?
Okay.
Okay, so there is a description of a biplanar osteotomy as well. But in this case, because, one second. Take off the periosteum there also. Periosteal elevator. इसको छोड़ो. अब देना. So we're going subperiosteally in this part also. Okay. So keep this straight like this, na? Patella facing forward, yeah? Okay, saw please.
Just for the sake of demonstration, sir, can you show us with the help of cautery the meaning of biplanar osteotomy in distal femur?
Okay, so normally you need, when we are doing osteotomy in the proximal tibia, as I showed, we go horizontal and then oblique this way, yeah?
Yes.
Now you can do that on the femur as well, and that's how it's actually been described both for the medial closing wedge as well as for the lateral opening wedge. The problem is when the bone is so thin, it's hardly 2 millimeters across here. So it becomes a little more difficult. So I will just do it as a uniplanar. It's the direction that is important, okay? So straight artery forceps है? KY दे दो मेरे को? हाँ? अच्छा. Okay, we've drawn the mechanical axis if you see on the X-ray, okay? Sorry, can someone focus on the X-ray? So if you see the X-rays, I don't know if you can see the lines.
So the preoperative angles we have measured, sir?
Yeah, so the lateral distal femoral angle is as low as 58, while the opposite side is almost 90. Okay, so it's a 32 degree deformity. The tibia is perfectly normal, if you can see.
Okay, so the MPTA was normal.
Yeah, MPTA is perfectly normal, yeah. So it's all femoral, distal femur, and as expected, because you have a physeal arrest, it's going to be at the level of the physis. Okay?
Right, sir.
So the idea is if we do a opening wedge with the distal part of the wedge close to the physis, you're going to have almost no translation in your deformity correction, yeah?
Okay, sir.
Accepted?
Accepted, sir.
Can you see the C-arm now? So I'm going to put my KYs as my guides. उसको हटा दो ना. Move that out ना. उसको हटा दो. Can't see with that, huh? देखा?
So on the lateral aspect of the femur, sir, the position of the guide wire should be almost in the center. Regarding the anteroposterior.
I'm going to put two guide wires. So one's going to be a little anterior, one's going to be a little posterior. Okay?
Okay.
I mean, is that okay?
Right, sir.
I mean, you can start almost central with this one. Show me. So I'm going to go like that. Show. दिखा. दिखा. Maybe a bit more. Yeah. दिखा. So your hinge is very close to the physis, yeah?
Yes, sir.
Okay, so we'll put one more there in the same parallel to that. बस काटने के लिए दीजिएगा.
The camera over the this X-ray monitor should come at perpendicular. It's little bit oblique, so the image picture is not very good.
Okay, at the Siam.
Yeah, Siam.
Okay, so this is parallel. Show me.
Mr. Rajesh, you
Show me.
have to rotate the screen of Siam. Whole
इसको
screen.
कैमरा के एंगल में करो ना.
Whole screen, complete screen. Yeah, not opposite way, opposite way. A little bit more, little bit more. Now it's perfect. And also change the light. Light is coming there. LED light thing coming over the screen.
The shadow of the light is on the screen.
बाहर पकड़ लो.
Reflection आ रहा है उसका. थोड़ा ठीक करो.
Very good, sister. Stupid. दिमाग ऐसे ही है. चलो, लीवर. 100 पतला वाला ब्लेड चाहिए. हाँ.
राजेश, लाइट का एलईडी का फोकस आ रहा है सियाम के इमेज पे. उसको शिफ्ट करो जरा लाइट के एलईडी को, या फिर सियाम का डायरेक्शन का. अभी ठीक है, अभी ठीक है अभी. और
एक और लीवर दो मेरे को.
मिरर एक को फोकस करो केवल कैमरा से. या दैट्स इट.
Okay. So can we focus here?
फिर लाइट दे दी.
So we've cut the K wire short and we are doing our osteotomy just above the K wire, okay?
So do you want to change the wire? One wire is going down, one wire is going up. So do you want to change the second wire?
So obviously change at some stage. Idhar na to? It looked okay earlier. I think when they moved around the C-arm, it changed. Okay. हो जाएगा. I think. Yeah, that's how it was going. Dekha? Yeah.
Siam
Dekha?
picture also? Yeah, it looks perfect now.
Dekha? क्या कर रहे हो यार? Don't do that now. You change the direction of this wire. Huh? Dekha? 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 No, okay, I think we'll accept that little bit of. एक दूसरा wire देना तो?
Yeah, it's look good.
I think this. अब दिखाओ. Okay, that's okay, huh?
Yeah, it looks perfect, sir. Great.
So then, we'll accept that much. Now, you can look into the field of the surgery, all right?
Yeah, it looks perfect, sir.
I'll just cut it with the saw, then we'll do the osteotomy. Ulta. 180 degrees. Yeah. So, need to make sure that your saw can go through without, just retract the back, keep the elbow, knee a bit flexed. ये क्या हिट कर रहा है इसको? दिखाओ. I can't see. Okay. दिखाना. सौ कहाँ है? को ठीक से दिखाओ ना. Turn the leg that way and yeah. Huh? Just use some brains. So I want to cut, make sure the back is cut also, no? So you don't want to damage the soft tissue, so that should be protecting you, huh? Okay, अब osteotomes दे दो. सबसे चौड़ा वाला मत देना, next वाला देना. Okay, so we're not going to use the broad osteotome because
intra of picture need to be little bit brighter. Yeah, it looks good now. Yeah, perfect.
एक बार दिखा दो इमेज, थोड़ा सा ऊपर जा रहा है ना. ओके, बस 100 दीजिएगा मेरे को, पकड़ो ना इसको, 100 दीजिए, दूसरा घुमा दीजिए. Change the direction a little bit.
So this is very important. Even you put the K
दिखाओ.
wire, you have to
Yeah,
check
that's
all
okay.
the time in X-ray also. The
Don't
osteotomy
mind it
line
going a little
with
away.
saw
इसको
also and
उल्टा
with
कीजिए.
osteotome also.
Bone is quite hard, so we'll use the saw a bit more. पूरा घुमा दो ना.
So would you like to put a medial hinge wire?
Back to that. You can.
Yes, sir.
दिखाओ. Yeah. This is hitting this. Can you cut the wires a bit shorter? We can take out the wires here. We don't need the wires. The wires are getting in our way, so we'll take them off. Because she's got hard bone. I don't think that should be a problem. And we are going to correct it manually. So, the. So we're going just above the physis. Dekho. Changing our direction. One sec. Keep it like this. अब देखो. Okay. उल्टा घुमा दो. हाँ ठीक है, चलो. दिखाओ. Is that okay?
Yeah, direction looks perfect.
Okay, sir. So how much of cortex you want to leave on the
Yeah,
medial
so
side?
we're going to change it around. So now that was slightly angulated, so it won't show us. Huh? देखा?
Yeah, direction looks perfect, sir.
दिखाओ. Okay.
Okay, it's going towards the physis.
That's okay. We were going to go up to there, no?
Yeah.
We won't go further.
So you are using osteotome that of HTO set.
Yeah.
Yes, thin and sharp.
So at least 10 mm of cortex you are going to leave, sir, on the medial side?
Yeah, we're going to leave. So in a child, you have to kind of fiddle around to see how much you need to leave, yeah?
Okay.
Because they vary how much they stretch out. So you have to be careful. दिखाओ. Okay, that's about right. Sure. Okay, happy with that?
Yes, sir.
Okay, so we'll put the second one now. Show me. क्या कर रहे हो? ना Stop getting. ये मोटा वाला कह दिए, बतला दिए. ठीक है, देखा? Okay.
Yes, sir, looks perfect. And the saw that you use is the same of TKR saw or it's different, sir?
No, no, we are using the thin blade one. And in this case, we use the thinner blade, not the broader blade, the narrow blade.
So for osteotomy, all the time it's thinner blade. It's not the standard saw blade that is used for the TKR or in THR cases. Okay.
तुम मुझे हाथ से गाइड करो ना कि उसको दे दो ना वहां लगाया
The
हाँ, you
suction
hold
and
it like that,
cautery wire need to be removed because it's coming over the C-arm picture. Suction
Yeah.
also.
And that is
you mean the levers?
and the visualization is
Yeah, we'll
something
just
that
take them
the
all out
ostomy
now.
hasn't
Suction and
completed.
cautery wire should be removed from
Okay,
the operating
okay, now
field.
take them all out. Okay, so now you can see that.
Yes, now it looks perfect.
बीच में क्या आ रहा है? ये काला बीच में क्या आ रहा है?
वही line is there something.
हाँ?
So keep it towards
gauze
towards
का
your
होगा वो.
side. Yeah. अब दिखाओ राजेश. Yeah, it's
What
fine.
is that?
अब ठीक है.
Huh? Something lying on the table, I guess.
कुछ experiment
चलो.
करते रहता है.
उसके कारण लग रहा था कि ऑस्टोमी कंप्लीट हो गया है.
You can get. So we take these out and now we'll check if it's enough or we'll do some more, yeah? So we can use the same instrument again if you want. Although this will not give you the full correction, we can at least use it to start off our correction, yeah? And I don't mind if the opposite cortex cracks a bit in these young children. They'll heal up anyway once you stabilize them. So, दिखाना दिखाओ. By the time it reaches there, it's hey. Okay, अब ये देना. So you are going to have to crack the lateral cortex whether you like it or not. So we're going to correct it now here. This much correction is not going to happen without the lateral side cracking up.
So do you want to advance the wedge spreader a bit more towards the ostomy?
Yeah, the thing is it is hitting the patient by the time it's reaching that much.
Okay.
Yeah, so that is just to start it off. We need more correction than this can give you, yeah? Come off. So now we'll do it with manually. Okay. So just show me. I'll leave. So you can just watch the opening out here. Okay, can you see that?
Yes, sir.
Yeah, it's opening out and it's going to crack suddenly. That's okay.
Better light on the operating field.
You want better light?
Yeah.
Okay, show me. Okay, correcting.
Yeah.
एक सेकंड ऐसे पकड़ो तो अब ऑस्टेटोन देना मेरे को. Let me just complete it with the. Yeah, drill दे देना drill K-wire के साथ. So what we'll do is we'll just complete it with some K-wire drills there. मोटा वाला दो ना मोटा वाला. ये point. Okay. What's happening to the patella? I don't know. Yeah.
Sir, correction angle is around 22 to 24 degree. So
No, we still have to correct. No, it's almost 30 degree, 32 degree on the calculations.
Okay.
It's 58 versus 90, so that's 32. 30 degrees at least, yeah? So I'm just going to do what? Show me. It's going down. Dekha? Now show me. Yeah. दिखाओ। Sure. I'm just making a number of drill holes through the opposite cortex through here only, okay? दिखा दो एक बार। Okay, now let's see. So the final thing is going to crack at some state. Yeah, so now it's going. Okay, let's see that. Okay, a bit more. So we're relying on the plasticity of the child's bone, yeah? Because I think we need to cut it through a bit more. It's not happening. 100 दे दो मेरे को. We're getting that much without cutting the lateral side, so we're going to have to cut it through because keep it at that much. Hold it at that much. Just going to make. I need. एक बार दिखा दो. You need to move out of my way, huh? You need to move out of my way. दिखाओ. ठीक है? Anterior cortex has not cut. दिखाओ. तुम्हारा ना लीवर हमेशा घसक जाता है. ओके. ऐसे पकड़ो. हाँ, हो गया. गुड. ऑस्टियोटॉम दे दो. दिखाना. ठीक.
The other camera on the operative side, please.
दिखाना. I'm going to cut all the way with the osteotome because it's not yielding. Huh? दिखाना एक बार. Okay. Yes, sure. Okay, that should be okay now. Just either. Just give me some. No, here. Counter there and this way. Okay, that's good. Okay, give me a wire. Okay, now you see the correction? Can you see the Siam?
Yes, sir. A big wedge has been created.
So I'm going to just put a wire across for the moment. Hold it. Sure? We're not worried about the growth plate on this side because the growth plate is already gone. And even on that side, really, because we don't want it to grow on that side. एक और दे देना. छोड़ दो. Leave it. We'll see what happens. दिखा. So that's holding it like that.
Okay, sir.
Okay, so now let's see this.
Can
So
you
the
shift?
patella.
Can you
we'll
shift the
look
limb
at
of the
it, it
patient a
seems-
bit? Because again, the shadow is coming.
Okay.
राजीव, नी को थोड़ा लेटरल साइड में लो टेबल के सर के तरफ. हाँ, अभी ठीक है.
इधर ले आओ ना ऐसे. हाँ. अब हमको ये दिखाओ. So now if you look at it clinically, it looks pretty good. ये देना. Diathermy cord. So initially it was way off. ऊपर जाओ ना हिप पे. चेक किया शुरू में. So a little more medially. दिखा. Sorry, a little more laterally. हाँ. दिखा. ये तुम्हारा सियाम में प्रॉब्लम है क्या? ऊपर में क्यों आ रहा है? इसको ऐसे रखो ना. पटेला फॉरवर्ड. हाँ, चलो
It
दिखाओ.
looks okay.
Okay, नीचे आओ. Ankle के पास. Keep the patella facing. थोड़ा ऊपर रखो ना. So, ठीक से दिखाओ. So that's slightly more, yeah, that's okay. Now, अब इधर knee में आओ. So it's still a little lateral, but pretty good, yeah? Okay? So this is
Yes,
where
sir.
we would normally do so little more correction we'll get when we
Some
hold
more
it like that,
correction
yeah?
if possible, sir.
Pardon?
Slightly more correction if possible.
Yeah, it's happening because the wires are not really holding
Okay.
fully. So I can just, up दिखाओ cord. So while I'm holding it like this, क्या कर रहे हो? But hold the position, na? One person has to hold the position. You can't do both things, yeah? You hold the position, हाँ. Yeah, okay, you can't do both things, yeah? चलो ऊपर दिखाओ. So now with the, so I need to go, ठहर जाओ ना, joint दिखाओ. हाँ. This is left ना, हाँ दिखाओ. You've gone
Dr.
to the
John,
other
Dr.
side. चलो.
Rajkumar here.
Yeah.
So would you prefer under correction or over correction?
I would want correct correction, yeah. A little bit over probably, but ideally I don't want to overcorrect, but just get it to the correct alignment, yeah. So if I have to choose between both, I would go to overcorrection because she's going to again go into a bit of valgus with time if we are not careful, yeah. Because the opposite side is growing. Although with the plate there, that will stop the growth to some extent. Okay, now let's see the knee. So you can see it's a little overcorrected now. Okay, so it's in fact quite a bit overcorrected when we do that. So we're somewhere in between this. Plate dena, lever dena mere. And a little bit of translation we'll get when we fix it, because so what are we going to use to fix it? That's a good question. So we have options of something like a philos or a distal tibial plate. We might use the philos here. Let's take the wires out because we don't need them anymore. Wire निकालने के लिए दो. Or we can put one slightly more distally. You holding it? Plate देना. दिखाना. So this is so what happens when you put the first screw, it will pull the shaft slightly laterally. So that should be good for us. Are you happy with the position of the plate?
Yeah, looks good, sir. Which plate you are using?
We are using the philos.
Perfect.
So this is off the label use, yeah?
Yeah.
But we have used the philos for the distal femur in children a few times for some of the bad fractures as well. कितना है ये? 36.
So any reason you are not using
So
any
34?
anatomical plate?
Sorry, I can't hear.
So any reason you are not using any other anatomical plate? Like a distal
Yeah,
femur lock?
you could use, we had the distal tibia medial plate with us. So you have to use a 3.5 plate, but the philos is a good one. If you can see that, it's sitting very nicely. And when we do this, when we tighten this screw, it will just pull the proximal femur a little laterally. So that is the amount of translation. थोड़ा सा पीछे रखो इसको. Okay, let's see.
So how you are holding the reduction, sir, right now, the correction that you have achieved? It's just manual,
Just
somebody's
manual, yeah,
manual.
because
Okay.
the lateral, the hinge on the lateral side is intact, yeah.
So would you
So it's
consider
just by
putting
pressure.
a laminar spreader from the top and keeping
Yeah,
it there?
could do, but we really have no space here, yeah.
Okay.
Anything we put in is going to get in the way of our plate. So I'm just going to use simple, so just use one regular screw here, then we'll go on to locking screws. So this we can actually go across the osteotomy if you want, yeah? But I won't do that. I'll just, because that's good. Measure. That, देखा? So 60. Yeah, 55, 60. 55 दे दो. We just need to check the lateral to make sure that the plate is sitting in the right direction. Which one was this? This one? Are you sure? नहीं. ये था. देखो. ये था ना? अब देखो. इधर है? पहले देख ले ठीक जा रहा है कि नहीं. दिखाओ. Is that correct? Sure? ऊपर नहीं जा रहा है. दिखाओ. Yeah, good. चलो. Screwdriver. We'll tighten this one a bit. Let's put one on top. Retract. Drill. Retract, I said. Drill. So that's the fourth. There's one more hole after this. Shall I measure? $28. Stop it. बता के रखो ना. I don't know where it's going here. नहीं. Just give me. I don't feel right. Don't think that screw has gone in the right place. एक ये देना तो. नहीं ये निबला या कुछ. So direction has gone wrong.
Dr. John, Dr. Rajkumar here.
Yeah.
Once
Tell
you
me.
have fixed some more screws, could you show us the alignment?
Yeah,
Final
I will
alignment,
do that.
and
I
then
just
we
want,
could
I'm
be,
not
we
happy
will be
with this
taking up some
particular
lectures in the hall, and
Yeah.
we'll
Absolutely.
reconnect with you once you are done with your final procedure. Is that okay?
तो उठा लो. Absolutely.
Sir? Yeah, okay.
Drill दे देना मेरे को. If I put this lower down, it should.
So would you be putting some screws distal to the physis also?
I will. I'll tell you why. I'll just let me get this stabilized.
So once you are putting the
that-
screws proximal and distal to the physis, then would it
Yeah.
behave like a epiphysodesis?
Yeah, we'll discuss that in a minute. Yeah, just give me 2 minutes. Question is that a good thing or a bad thing in this case? Reverse. No wonder this. हाँ चलो measure. 32. So I think, yes, it will of course work like an epiphyseal, but this side the epiphysis has gone anyway. Yeah?
Okay.
The lateral side, the physis has gone anyway.
Right, sir.
Medial side, in a way you want it to not grow for the time being, yeah? Because if
Okay.
it grows, then it will again cause a deformity.
Right.
So it's a good thing, in fact, that it will stop the growth. What is happening here? Which way was it? Measure दिखाना था एक बार तुम लोग ना उसको उठा के रखो ना you guys are
Guys,
moving at the
any
time.
questions from the
Yeah.
floor? Hello?
Just 1 second. I just need to get this, yeah, direction right.
Rajiv sir, any questions? No questions.
So we'll check two things once we've done this, whether the patella is tracking okay. We'll just put a couple of more screws and then do that, and then we are done more or less. Unless we have to do something for the patella, which we'll show later. Okay, so that's good. Now let's do, so locking then up. So now we go on to locking screws. You can put दिखाना एक बार go into the so these will go into the epiphysis. दिखाओ. Okay. Measure 50. दिखाओ कितना है 50 55. This plate is still a bit anterior on top here. And पीछे. So I need to change that a bit. This one? पीछे वाला तो ये था. Okay.
John sir, meanwhile, can you explain about the patella now and also?
Yeah, we can check
trachea?
that.
Yeah.
So if you see that, one second.
Cameraman, please.
It's still a little lateral, yeah? And that's not surprising because it's been there for so long. You see that?
Yeah, it's little
Okay.
bit lateral, but
So
better
that's why I
from
said
before.
this is probably just the osteotomy may not be enough. We'll do some releases, but first let me get this plate right because I'm still a bit unhappy with the position up on top.
Sir, you continue with your surgery. We'll back.
Yeah, come back. Let's get this
we
corrected.
are starting some lecture. Thank you,
Sure, sure.
chairpersons.
Yeah, we'll come back to this.
Yeah, and
Hold it, hold it.
the next session we are combining the multi-ligament and the cartilage session. And the chairpersons are Dr. Binod Thakur sir, please come on the dais. Dr. Manoj Chaudhary sir, please come on the dais.
That's better.
Dr. Deepak Joshi sir. Dr. V.K. Sinha sir.
We'll put the upper
And Dr.
screws
Kanhaiya Singh
first.
sir.
Okay, now, jahan bhi jaoge, come to the top. 1 second, I'll tell you when. First, let's take this off completely so that there's no confusion.
And there is some modification in this. I am skipping my lecture because that has been presented many times because of lack of time. So the first case presentation is by Dr. Somudeep. Dr. V.K. Pandey has left for his train because it was little bit late. So Dr. Somudeep, your case presentation on multi-ligament knee injury. Then followed by the lecture of Dr. Rajkumar sir and Dr. Deepak Joshi sir.
Important. It's very important session, really interesting about the ligament injury and the cartilage injury. So our first speaker is Dr. Soumyadeep Datta. Speaking on multi-ligament knee injury, a real good thing that will give you an insight of the such situations. Dr. Datta, please.
Thank you, sir. So it's a tough topic always. Multi-ligament is a challenging surgery. There is no doubt. I think experts like Amravati sir and all of the experts will agree that multi-ligament is always a challenging. And so I'll present a case something different. So this is a 38-year-old male presented with following an RTA. So this is an X-ray. The X-ray is obvious. There is a fracture in the fibular head, suspecting of a lateral collateral or lateral complex injury. Another is there is a fracture on the medial tibial condyle. So on further evaluation, when you go to the CT scan, there is a intra-articular fracture on the medial side and there is a fibular head fracture. So on MR, surprisingly, when you see the MR, so this is the MR taken, knee is subluxated posteriorly because there is no cast. So there is something there in the posterior side, support is not there. And if you see that this is there is a lot of bone bruise there, and obviously there is a fracture on the medial condyle. Medial collateral seems to be intact, and there is not much, there is the bony fracture there down in the fibular head. So this is, sorry for the bad X-ray. So this we have. So anything, Amravati sir, what's your plan? How do you take, sir, this patient on X-ray? These are
I think you have an arcuate fracture.
Yes.
That is correct. And any other thing that they have given you on the MRI reporting, what they have given you? That much
this
I
is
only can say.
lateral side, the lateral ligament is intact. Yeah. There is no intra-substance injury. There is a injury on the down in the fibula. So, and MCL is more or less intact. There is a PCL, there is seems to be a tear because that's why tibia has been subluxated posteriorly. The posterior support is not there. And I think ACL is also not seen. So obviously we are dealing with lateral side, posterior side, and anterior cruciate also. Medial side, I think there is a fracture, not much in the medial collateral there.
Okay. Considering that MCL side is fine, you have a knee that is subluxated like this, and you have an arcuate fracture. My concern would be for a subtle examination of your vascularity, which always you should do.
Yes.
You need to do ABI index. So the ankle brachial index is an important thing that you have to do. So with that sorted out and there is no vascular issues, then you need to, really get the knee back into position, hold it on for that point of time, let the acute phase settle down, and then probably you can do your extra-articular first, and then you can go for your intra-articular reconstruction as the knee settles down. But the most important thing that you do for me in this situation would be to rule out a vascular issue. Sometimes it can be only an intimal tear, and probably when you start doing your procedure, you will land up that you will have a situation post-op wherein the limb will become blue. I had this situation. So it is important for everyone to do the ABI and the vascular study up front and then treat the ligaments whatever way you want to do.
Yes, limb first, then the ligaments.
Somu, can you go back to your X-ray, please? So this is the X-ray showing hardly little bit of very smaller bony chip avulsion from the fibular head, from the anterior part of the tibia, or maybe little bit on the medial aspect of the tibia. So whenever this situation, whether it's the knee, whether it's the ankle, as smaller is the bony fragment injury is there, the severity of the ligamentous injury is very high. If
Yes.
bony fragment is bigger, ligamentous injury is lesser. If a smaller is the bony fragment, bigger is the ligamentous injury, like in this case. This was almost a case of dislocation, but if you see very lightly, the X-ray looks absolutely normal. Little
Yes.
bit bony fragment is there. So this should be the message for us, that if there is 2-3 bony fragment avulsion around the knee joint or around the ankle joint, it means it's the massive ligamentous injury case. And again, as sir has said, you should not miss the ankle brachial index, because 50% of the knee dislocation get spontaneously and immediately reduced by itself or by reduced by simple maneuver. So when that patient comes to you in your OPD, it doesn't mean that knee was not dislocated. It was dislocated, it got reduced. And if you miss the ankle brachial index, very high chances of this losing the limb, because literature say almost 30% of such type of injury will have injury to the popliteal artery.
Yes, I think that's the message we should all get, that these multi-ligament cases, our vascularity should be priority, because without checking the vascularity, CT angio, or like this kind of investigation, without going taking this investigation, you should not take the patient to the OR, because you are calling the trouble there. Deepak sir, any take on this? Anything else?
Ankle brachial is okay, but always we have really we had an even after the patient who come, even if we feel the distal pulses are there, sometimes we
Yes.
have some intimal injury and some narrowing at the popliteal artery level. So as a rule of thumb, we always get a Doppler done in all the cases now of multiple ligament injuries.
Any comments, sir? Kanaya sir?
There is only one comment, that the vascular injury is usually acute and very much evident. If it is not, there is one trap, that you do everything and there you see, especially clinically, that the vascularity is okay, but there is gradual thrombosis due to intimal injury of the
Yes.
popliteal artery, and the vascularity gets worse and worse, and you notice it later on, and you are implicated that there is some fault in the surgery, and that has led to the...
Yes, yes.
So
They are creating
one should
medical
be
legal
aware of
issues
that.
later. So without, because we are running late, so what I have done is that this is the thing I went in and I found there is a avulsion kind of injury, that's a peel off of the whole PCL from its attachment in the medial femoral condyle. What I done is that I taken the patient around, I think on the 12th day around. So I thought that this PCL can be repaired. So we thought that we will take a chance of repair. We use a fiber wire and the ethibond to get that bite in. Then we tied this up into the medial femoral condyle, and we have fixed the medial condylar fracture with a plate and the fibular fracture with a screw. And during paraoperatively, I have checked that we have got the knee back into its position. So anything different? I am prepared going for a PCL repair. Yeah. So I think, sir.
This is a follow-up X-ray, correct?
No, I think it's a post-op X-ray, immediate post-op.
And you don't use staples or any
No, this
sutures
is, I
post-op?
think it's a no, I don't use stitches.
Okay. Consider this is a post-op X-ray.
Yes.
Do you want to prefer to take X-ray in any particular position so that you would like to see any instability in the knee?
I've checked perioperatively during CM and put the patient on cast.
Okay.
This is, I think, after stitch removal, this thing was, I think around 4 weeks time, we put the patient on cast for 4 weeks. Generally, these patients with the cast with the posterior support I discussed in the yesterday. So we.
Do you still want to take the kneeling X-ray and just make sure that everything is fine? Or you will accept some amount of laxity in this case? I know it is, open surgeries are not ruled out.
Yes.
Okay, the message should be here that it is not always arthroscopic.
Yes, yes, of course.
Open surgeries still have a role in certain situations like what you have shown, it can be done. And like Deepak also agrees on those lines. But yes, you need to keep following up these patients so that the results probably here, I can see that the tibia is still little subluxated behind. And if you could have proper x-rays, then it will add value to what
Yes, of
good
course
work you
there
have
is
done.
always
Yeah.
a chance of it. So I think that's it, that's the X-ray. So you can say that is some grade 1 laxity. This is the follow-up, I think around 1 month time. And this is the follow-up. You can see there is some kind of subluxation posteriorly, but I think patient having a reasonable good function. In a multi-ligament scenario, I think this patient doesn't have any clinical problem. I'm not very eager to go taking the patient for an OR until the patient having any clinical problem.
Also, Somu, on the lateral or posterolateral side, it's better to augment with the suture also. You take lot of suture around this lateral collateral ligament over the fibular bony part.
Yes, we have done. The suture also, screw with the sutures in the lateral cord. Anything? Sir, you want to say anything? So that's it. I think that take-home message is that the PCL is the pivot of the knee. The concept is that PCL in a multi-ligament scenario, whether it is a PCL, then you have to do the recent studies also shown that the PCL you have to do first. And then you take PCL repair is an option when you are dealing in an acute scenario. There is or reconstruction is always there as shown yesterday. And after PCL, you can take out the collaterals. So there is a lot of debate whether you do collateral first or PCL first, but there are now studies are coming that you should do PCL first. Then you go for collaterals. In multi-ligament scenario, mostly you can leave your ACL for later if the patient comes with a laxity. Thank you. I think anything.
Yes, there is one thing that I would like to draw your attention is that in this multi-ligament injury, you must also focus on the capsule of the joint.
Yes,
because there is often injury, there must be some injury to the capsule also. And they also need to be repaired. And it's very good to plan beforehand in your mind that what suture you are going to take when and which one to be tightened first and second and third. So there should be complete planning for this surgery. Okay, very nice presentation. Thank you very much.
Thank you, sir. Thank you.
Next speaker is Dr. Raj Kumar, Amravati. Dr. Raj Kumar, please.
Before Dr. Rajkumar is coming, I invite you in Nailscone 23 at Rajgir. Rajgir is a very good place, we all know. And as an organizing chairman, I, with folded hands, invite you at Rajgir.
So good morning, and we are coming to the fag end of the wonderful scientific session of 2 days. And I thank Rajiv and his team, and thank Dr. John and the team in Patna for having us come here and be a part of your deliberations. And my charge today would be to discuss autologous chondrocyte implantation as Rajiv has requested. And without wasting much time, the incidence of these kind of injuries, cartilage injuries, should be around 36 to 60%. See, the amount of injury is high. Now, you have a lot of kids with Khelo India coming into play. Everybody wants to be some kind of a sports person. For two reasons. One is it will give them an opportunity to stay fit. Second is to get some jobs in the government sector. Third is to be different from normal population. So that is a good sign for a young India. That is our general population that we have. If left untreated, these kind of individuals will have a lot of disabilities, and that is the reason we need to have ways and means of managing these kind of injuries. If you look at the etiology of these kind of fractures, these kind of injuries, the cartilage ones, is direct trauma and overuse. Those are the two important things. Apart from that, when you look at the alignment and the rotational problems that these injuries have, will be also a cause of concern. Now, when we select patients to do manage these kind of injuries, there are two knees that we can distinctly differentiate. One, we call it as a green knee. The second one are the red knees. The red knees are one with comorbidities, which is in this fashion. You can see that all the inflammations, all the previous injuries, previous surgeries, and larger lesions do fall into a category of red knee. And the green knees are the one which are the virgin knees with the cartilage injuries that were shown in the earlier lectures. Outer bridge classification is a good classification that we all should know in clinical practice. There are 4 grades that are classically described. The blister, the fissuring, and the 50% loss and more than 50% loss of the cartilage. However, these classifications are described on the arthroscopic findings. We also would like to know the Kellegren-Lawrence classification also to help us plan these kind of cartilage injuries. Now, surgeries for chondral defects can be done in these 4 broad categories. One is the chondroplasty, second is by myriostimulation, third is by osteochondral restoration, then there are cell-based surgeries which are of advanced nature. Myriostimulation is a good procedure which can be started off when everybody used to do, and they are basically done when the cost factor is in concern. We also would like to do this to reduce the failure rates, but of late the literature is coming up to say that these kind of procedures are not to be done because they will cause a lot of subchondral fractures and damage, and you can have reissues in the joint which can be a cause of concern. Oats is an important procedure that you can use to transfer the cartilage from one part of the knee to the other part in this fashion. And the limitations can be a donor site morbidity, and the size, if it's larger in size, we will not be able to do that. And the morbidity can be between 2.3 to around 12.5%. Allograft transfer is a challenging way of managing these kind of osteochondral defects. If you have access to an allograft, this would be a good option to match this graft to the lesion in this fashion, and then transfer this if it's a fresh allograft that is available for you for use. However, the failure rates are between 80 to 50%. Particulated cartilage transfers are coming into vogue now, and this can be used in juvenile athletes with greater success. Allografts, as I mentioned, can be also used, which are cryopreserved, and they will come in different forms, and then you can use as a option for managing these cartilage defects. Cell-based surgeries are like the autologous chondrocyte implantation. The only problem with this is it is a 2-stage procedure. Patient has to be counseled with that, and then the culture has to be done for the cells, and then implantation in 3 weeks when the cartilage cells are ready in the lab. The overall failure rate is around 10%. It is good enough. The salient features of these procedures are: one is you harvest the graft, then you culture the cells in a lab, then you transfer the graft material onto the patient's body in this fashion. A treatment algorithm has been described by Rob Laprada and his group, and it is worthwhile for you to read this article and then plan your surgical procedures. To illustrate what autologous chondrocyte implantation is all about, I'll just present to you this 47-year-old female teacher who is a nun by profession and a teacher as well, had come to us with the history of constant knee pain lasting for over 6 months. But when probed, she was able to recollect that she had a very trivial fall in her convent probably around 8 to 10 months back, and then as a result of which she had this pain recurring to her over 6 months now. The X-ray was unremarkable. When you see an X-ray like this, you will not be able to see much. But when you dwell deep into the investigations of this patient, you can see that subtle cartilage injuries of the patella, which are in this fashion, showed to you. And you can see that there is a cartilage injury of the patella here. So when we scope this lady on table, it is difficult to measure how much of the defect this patella has got because the patella articular surface is in a V-shaped fashion. However, this is a rough measurement that we took on diagnostic scopy, and these are the images that you can see on the scope. The cartilage is not great, and you can see that there is a lot of cartilage that is wasted and worn out in this individual. And that is the way we measure roughly to give us a rough idea that if it is less than 2 centimeters or more than 2 centimeters, this is the way we harvest the osteochondral plug arthroscopically. You can do it either from the lateral femoral condyle or from the medial femoral condyle. The depth of osteochondral plug should be at least around 10 millimeters or 15 millimeters is good enough, because we need a bone at the base of the cartilage to transfer and that keeps the cells viable till it reaches the lab. And this is how the osteochondral plug is transferred onto the OsGrow material transfer box. And then the patient comes back to us after 3 weeks. We take a midline incision in this fashion. We can see that the area where the harvest site was done, we clear off and measure the cartilage defect, and luckily on this patient this was of this shape. We need to see whether the cartilage plugs on this side are stable. Whatever little cartilage that is left is to be taken off, curated, and the whole area has to be freshened so that the margins of the transfer are stable. We now then create small areas of microfracture by resecting the cartilage at the margins. It is important to have a stable margin because this cell should stay there. And once we are sure that the cartilage margin is great, we will take the fibrin clot along with the cells and then try to do microfracture on these areas and layer the cells in this fashion. We have a bone wax marked around the margins of the patella because there is a possibility that the cells that you are layering can, sweep down the downslope of the patella on either side, the medial facet as well as the lateral facet. We have a definite setting time for this, and once we check the setting time, and when we are sure that the cells have set, we now would want to move the knee in this fashion and see whether the area where we are transferred are stable or it peels off. This is the moment of truth and the magic. Your heart will come into your mouth, but lo and behold, you can see that the cartilage that your cells you have transferred are stable in spite of the knee being moved vigorously. Once that is done, you need to follow up this patient, and the sister has sent us these images. She is transferring 2 flights of stairs, negotiating without pain. She is able to transfer, sit, and move around happily. and the patient at the end of the procedure is comfortable and happy, and that's how she is in the current mode now. So autologous chondrocyte transplantation can also be combined with bone grafting and then layering the cells on it, which we call it as a sandwich technique. If you see a larger cartilage defect with bone loss, but you should be very skeptical of using these kind of procedures when there are bipolar lesions, because the results in bipolar lesions are not great. So the recent literature also tells about how we can use advanced techniques for managing the red zone areas, and they are basically an experimental basis. And once they come into market on a larger scale, probably when the randomized control trials are available, this can be used very frequently. But as of now, all these are for experimental purposes. The scaffolds and all those things. It is good to read and write your answers in the exam, but how much you can use it on your patient who can pay by his own pocket is a matter of debate. Thank you so much, and I invite all of you to be IAS members, and also if you would like to be a part of the Karnataka Arthroscopy Society membership, I invite you for that, to be a part of members. And for the 2024 IAS, I am giving you an open invitation, and I request Rajiv and other members here to be lead from your end to come to Bangalore in 2024 for the IAS. Thank you so much, and thank you for having us here.
So, very, very thank you, Dr. Raj Kumar, for your nice presentation on cartilage injury. Any question, please? No, I don't think so. Now I call on next speaker, Dr. Deepak Joshi, for his osteochondral lesion lecture.
So the last batsman, the last lecture of this meeting, wonderful meeting. I thank John sir and Arvind. Very close. One of my first president, always proud to be with him, and all the team of Paras Hospital and organizing team. So my talk is on osteochondral defects. More or less everything is covered, and it's sort of a revision if I take for the resident sitting here. So osteochondral defects, if I look at the osteochondritis dissecans, I start with that. So that everything is intact, it just a fragment is there, it is not loose. Grade 2 or 3, when it is loose, we can do sort of a drilling or a K-wire or a bio K-wire fixation or a Herbert screw fixation. And if it is displaced, we do an open refixation or reconstructive procedure. That one of them was shown very nicely for the patella today, and the same thing can be reproduced for the condyles using a bio K-wires or using a knotless anchor with a fiber tapes. So this is how the treatments has changed over a period of time for management of the osteochondral defects, with a lavage to chondroplasty to drilling to microfracture to OATS to ACI. So lots of procedures have come, and probably today there are two procedures: OATS, that is the osteochondral autograft transfer, and the ACI is the two procedure which has now in line. So what are the treatment options? So it can be palliative, which is the lavage and debridement. It can be reparative, which can be the drilling, microfracture and the OATS, or a regenerative, that is the ACI and the stem cell therapy. Very nicely have been covered with the previous lecture. So this is the indications that we use. If the defect is less than 2 centimeter, we can do a microfracture if the patient is maybe a little older. Not a very good procedure. It is just generating a fibrocartilage. So if it is in a non-weight bearing area, we can go for a marrow stimulation or a microfracture. In a weight bearing area up to 4 centimeters square, we can do a OATS. It can be done in arthroscopic or a mini open way. The large defects more than 4 centimeter or even more than 2 centimeter, the ACI is has come in a big way, which is of various types. Microfracture already covered. The idea is to create a trough edges which are basically sloping, and so that the we just create an all into the basically the subchondral bone and create a mesenchymal clot and protect it over a period of time so that the fibrocartilage grow over that area. Osteochondral transplantation or the mosaic plasty has come in a big way, and I think we started doing in around late 2000, I think in the first decade, and it has stood the test of time, though it creates little bit of incongruency in the cartilage in the weight bearing area where we are putting this graft, but it has stood the test of time, and the patient do well with this sort of a procedure as it is hyaline to hyaline. So this is a small video borrowed from the author. It's a cadaveric video. So we first measure the cartilage. So it is available as far as the arthritis is concerned. It is available in 6, 8 and 10. We have other also companies which are making this sort of devices where the bone is drilled and the cartilage is fixed. So these are the areas from where we can actually take the plug from the trochlea and from the edge of the basically near the notch. So we go 15 millimeter from the non-weight bearing area of the trochlea near to the cartilage. So 15 millimeter is the recommended plug that we take. So this is how it is seen. We have a bone in the tube. So and so that was a donor area, the uh, donor graft, and this is how we take another plug that is from the area. So we take the cartilage part of the bone and as well as the make a hole. So this is how the plug goes. So this the thing that is being transferred, it is little bit more, it is a little bit diameter of it is little bit a millimeter less than a millimeter more, so that it snugly fits. So this is how it is stamped into the plug. So that's how the oats looks like. It looks very good in the cadaver, but lots of time it is incongruent. When we are putting this, we have to be very careful that our needle has to be put. It should reach the area at a perpendicular site. ACI has been very well covered. First surgery is where we culture the cells and a plug, and the second surgery we put a cells and cover with either a periosteal flap. That was an earlier ACI available, but in our country I think we have the regrow that is giving us, it is a gel based system. ACI has come in a big way for more than 4 centimeters square, and even in the patella for very nicely shown in the last studies. Contraindications are the ligamentous instability. You have to manage that first. We have loss of meniscal function, malalignment, or we think there is some inflammatory pathology in the synovium. Probably we should not use things. The cells may die, and the tobacco use, and in a very obese patient also this may fail. Diagnostic very well. First stage we take the biopsy. Second stage the chondrocytes are about 4 to 12 million chondrocytes can be cultured in about 3 to 4 weeks, and we transfer. So various techniques were there where the first ACI, the cambium layer of the periosteum is stitched over the cell and the fibrin glue is applied over that. In the second generation, the porcine patch used to be applied. So it is good that the advantage of it was that no patch hypertrophy usually seen, and there was no morbidity on the tibial side from where the periosteum used to be taken. The disadvantage is as suturing of patch was still necessary, so the cell leakage is a problem. So we have a scaffold base also was there, which is expensive, and then this is how we. So I would like to show, I think this was our first case of ACI. You can see the graft. So we curate, we make some holes, plugs, which was very nicely shown, and we put a gel. So that's a weight bearing area. We did the repeat arthroscopy of this guy, and so you can see it is fixed, and then it really grew very well. So the allografts are used for very larger, more than 4 centimeter squares. I had seen few of the Densha cases earlier when he was in KM. He did lots of megawatts and the allografts. But again, very difficult to harvest and predict how good they will do. It is very difficult. So This is also was discussed, so we can, this is also coming now, a juvenile cartilage allograft. So we meshed and cartilage and bone, it is still in experimental and we fix it with a glue. So as was shown earlier, lots of thing engineering is being done for the cartilage still in the way, and lots of products are available, have been available, some are withdrawn, available in the market. But probably right now we have only, for practical purposes, we have OATS and the ACI for the larger defects and OATS for the smaller defects. Thank you so much. And on the behalf of, I think, Dr. Ashish, we should all attend this KGMC conference, the annual conference of Indian Arthroscopy Society on 1st and 2nd of September this year. Thank you so much.
So thanks, Dr. Joshi, for your nice presentation. Any queries, any questions? Oh, nothing. So Dr. Adbin, please.
Thank you, Chairperson. Uh, May I request Dr. Rajiv Raman to felicitate Dr. Deepak Joshi. Ready?
Image and just run the video. So it was still maltracking, so we did a Ru and Y. Okay, I'll just show you that.
OT video, please. Yeah.
Can you see the thing?
Yeah.
Are you able to see what's?
Yeah, it's visible here.
Yeah, so that's the patellar tendon being identified. So you can see how the patellar tendon is actually quite lateral. Yeah? Tendon there?
Yeah, it's visible there.
There's a bit of glare, unfortunately, because at that time these guys were not looking at what they were doing. But I'll show you this. So what we did was, we did a Ru and Y. So they'll just show the cutting of the tendon. 1 second. Tendon काटते हुए कहाँ?
John sir, is Bhushan here?
I think it may be better for me to just show it on the surgical site. इधर आ जाओ तुम लोग, लाइट थोड़ा कम करो. इधर आ जाओ. So, can you see now?
Yeah.
So this was the patellar tendon here. This was the lateral part of it, which we split down the middle here. You can see that? Yeah? So this, can you see that?
Yeah, yeah.
Okay, and then we took it under this medial part of the tendon. We raised an osteoperiosteal flap here, and then we are still about to tighten it, but we are suturing it under that periosteal flap there. Okay, like that. Okay, and then once you are doing that, then the patellar tracking, flex the elbow, is quite good. Okay, see that?
Yeah.
Yes. All the way there, the patella is still tracking okay. Although obviously the trochlea is not normal, but you can see the tracking is pretty good all the way. We did some lateral release also, of course, so we bend it. So all the way there is tracking quite nicely. See that?
Yes, sir, we can see.
Okay, so that's now the osteotomy, the corrected this thing after the fixation is there. वो वाला दिखा दो, the alignment. Alignment वाला दिखा दो. They'll show you the alignment films. एक सेकंड यही वाला दिखाओ ना, ये एपी एक्सरे दिखाओ, एपी एक्सरे. Okay, so you see the AP X-ray how the cortical screw has pulled the proximal fragment a little laterally, so that takes care of the little bit of translation, because our fora is not exactly at the point of the deformity. It's a little proximal. Yes. So when we are doing this, it is putting the mechanical alignment axis normal, okay? And we can see the mechanical axis. दिख रहा है, इधर दिखा दो, इधर ही दिखा दो. So just show it here. इधर दिखाओ. patella should go forward, huh? Abhika? Okay?
Yes, sir.
Ankle पे जाओ. Yeah. Bit medial. Bit medial. Okay? Yes, it's घुमा दे. Abhika? Okay, that's center.
Yes.
Now come to the knee. Because sorry, this is one. Let's do it again. Shiva, ऊपर दिखाओ. मुंह मत करो ना बीच में. One, two, medium. I need to go more lateral. Okay, that is one, two, medium. Okay, sure. अब दिखाओ बीच का. अच्छा, अब दिखाओ इधर. ये हिल रहा है ऐसे ना. Keep it straight, yeah. हाँ, ठीक है, चलो. अब इधर दिखाओ. Okay, so it's dead center there now.
Yes,
Okay?
sir. It's perfect.
Yeah, so that's good. Now it's tracking quite well. Whether we need to do a bit of medial plication or not is a matter of this thing. I think it's holding up to here quite comfortably, yeah?
Yeah, it's sitting in the trochlear groove.
Yeah, so I think we'll leave it at that, and then hopefully once this patella sits in the right place, the trochlea over a period of time will reform. Yeah?
Yes, sir.
Because it is still growing. Of course, we may have to do something for length later. Yeah?
Yes, sir.
Okay, so I think we'll stop. Tuti ke khol do.
Thank you, sir. Thank you, sir. Thank you very much.
Okay, thank you. I think I have to wait for the airport, so maybe to.
So, sir, you have to come at Muriya also, sir. So, we are coming to the closer of the session. Before that, I want to make one announcement. Dr. Rajkumar Amravati from Bangalore, he is contesting for Vice President of IS 2024. So, kindly support him in a big way. And IS Con this time is at Lucknow, and Dr. Ashish Kumar sir, he has just left because he is here only. So Ashish sir, please. So he has done most of the preparation. You can come to the Lucknow and enjoy the Lucknow kebab and all the hospitality of Lucknow. And at the end, of course, arthroscopy part also. So Ashish, Ashish sir, please, some words from your side.
And Sarvan, I had shown in my slides also. So I request everybody to kindly block the dates. This is 1st, 2nd and the 3rd of the September. And on the 31st August, we are going to have a cadaveric workshop. It's all going to be a nice show. And I expect everybody to please consider it and be there and do register at the earliest and ask others to do so, especially those from the teaching institutions. Kindly promote your residents to do it at the earliest. It is up to the 15th April, the early bird one. So, and for others as well, we are able to give residential best choices if you do it early. Thank you very much. Thank you.
Thank you, sir. And also a big round of applause for Dr. Rajiv Raman, who became the Joint Secretary of IS. And there was no contestant against him. That was the big thing. So Rajiv boss. And he used to come in this course from first course. And all the time he has spent 2 days. And very big support of Dr. Rajiv boss from very early days. And at the end, I also would like to thanks to all the moderators, all the speakers from outside, starting from Bhushan sir. He is also very big supporting to me. He also came many a times in this course and traveling from such a long distance, and always he has stayed for 2 days. This time Ashish sir and Somu Deep, and of course Dr. Rajkumar sir. He just accepted in a single times. I said, sir, you have to come to this course. He said, yeah, I am ready. You just tell me the date. And he took the flight in morning 4:30. He was at the airport in the morning 3 a.m. So thank you very much, sir. And also Dr. Sudeep sir, Dr. Abhinas, Dr. Mani sir, Dr. Rakesh sir. He again always from day one in all the courses with me. Dr. Deepak Joshi sir, first time, but he liked the things, he appreciated much. Thank you, Deepak Joshi sir. And all other faculty, moderator, thank you very much who are here. At the end, the OT staff, starting from all the sisters, audio visual guy, and in the last, this Arthrex guy and the Sironix guy. He supported in the last Sabah, and of course all were support from mostly from the Paras Hospital, and this was under the Paras Hospital and the ORIF. That is one of the organization. He deeply involved in the education part. This ORIF is taking this 1 hour every Tuesday webinar almost from for last 3 years, and in between there is lot of this conferences and workshop also. Again after 2 to 3 weeks we have again one conference at the Kolkata under this ORIF with North India Orthopedic Association under banner of that. Thank you everyone. And credit must goes to the Paras team. If anything lacking, you can blame on me, and any credit should be given to the Paras team. Thank you very much. Thank you. And last, and co-organizing secretary, Dr. Vikas Kumar. He is standing for me from day one. He is calling everybody, taking care of everything, bag, memento, badge, everything. Thank you, Dr. Vikas. I request everyone for a group photo here. Kindly come on the stage. Bhushan sir, Joshi sir, Deepak Joshi sir, Bharat, kindly come on the stage for a group photo. Dr. Manish Ranjan, Dr. Ratnesh, Dr. Aswini Gaurav. Dr. Ratnesh is also was very active in making this scientific part. Dr. Jasbinder, kindly come on the stage. Dr. Janki, everyone kindly come on the stage, please. Dr. Bhatt was, please.
रजिस्ट्रेशन करवा रहा हो सर आईएसकॉन के लिए
मेरा नेल्सकॉन भी है
नेल्सकॉन
सितंबर 22nd to 24th at राजगीर
एडमिटेड राजगीर अच्छा है
नहीं ग्लास ब्रिज